Dear guests, colleagues, and friends, I welcome you to the virtual symposium of the Arab Society of Nuclear Medicine, Teranastics in the Arab World, Road to Kyoto. This symposium is the fruits of collaboration between the Arab Society of Nuclear Medicine, the World Federation of Nuclear Medicine and Biology, and the European Association of Nuclear Medicine. First at all, I would like to thank the President of the World Federation of Nuclear Medicine and Biology, Dr. Jean-Luc Urban, for his role in making this collaboration real. Thank you, Jean-Luc. This symposium, Teranostics in the Arab World, Road to Kyoto, is a first step in a unique opportunity for new collaboration that will offer attendees a comprehensive overview of the newest development in molecular diagnostic, state-of-the-art imaging, and molecular precision treatment, Teranostics. From our perspective as Arab Society of Nuclear Medicine, we are seriously working to increase knowledge and training in the Arab world, making great efforts with all our experts to make Teranostics available in our countries. We are looking forward to witnessing the impact of this conference in bridging gaps and enhancing collaboration between all relevant physicians for the optimal outcome of patients. We hope that our physicians will have the opportunity to learn optimal modalities of diagnosis and treatment in order to help the treating physicians in implementing these new approaches into their current therapeutic strategies. Dr. Jean-Luc Urban, Dr. Akram Al-Ibrahim, World Federation Nuclear Medicine and Biology team, European Association of Nuclear Medicine team, and the organizing committee, we thank you for your collaboration and your hard work to make this unique opportunity real, and we look forward for a very successful symposium. Thank you very much.
Thank you, Dr. Mohammed. Maybe Professor Jean-Luc, the President of the World Federation of Nuclear Medicine, would give a welcome note to the participants in this symposium. Please, Professor Jean-Luc.
Thank you very much, Mohammad and Akram. I remember a few years ago in one of the a meeting of the ARSNM, I met with Akram and Mohammad, and we were talking about the Arab Society of Nuclear Medicine joining the World Federations. That was materialized a few years ago. This is probably one of the best things which ever happened to the World Federation of Nuclear Medicine, is having the Arab colleague joining the World Federation. I have to tell you that I'm mostly impressed with what Mohammad, Akram, and the organizing committee have been able to pull out over the past few weeks to organize this symposium with more than 250 attendees registered a few days ago. The quality and the speaker and the level is formidable, so, and I'm sure it's going to be a great success. My request is basically I need you guys to share your secret about organizing such a short period of time, a very high level, and I'm sure successful meeting. So thank you very much for stepping up to those lectures and webinars to the road to Kyoto. And I hope to see many of you in the next few weeks and months, and at the end of next year in September in Kyoto. I cannot wait to have face-to-face, maybe I'll be mass-to-mass, but at least in-person meeting. So thank you very much and congratulations.
Thanks a lot, Professor Jean-Luc, for your kind words. And we are looking forward to more collaboration with the World Federation of Nuclear Medicine and the global nuclear medicine community, actually. With this, we will start now the first session of this symposium. And our first speaker for the first session will be Dr. Mohammad Haider. Dr. Mohammad Haider is the president of the Arab Society of Nuclear Medicine. He is an associate professor in nuclear medicine and clinical radiology at the American University of Beirut, and he also a senior advisor to the Minister of Health in Lebanon. He will be discussing the Lebanese experience in theranostic in prostate cancer in both diagnosis and the treatment, and he will give a highlight about the progress of this field in Lebanon. Dr. Mohammad Haider, the floor is yours.
Thank you, Dr. Akram. Thank you, Dr. John, for your kindly words. We'll start with prostate cancer. As you know, is the first cause of cancer in men, with almost 20% of all cancers in males. Prostate cancer is the second cause of death. Almost 9% of cases in cancer are from prostate cancer. So in Lebanon, we have almost the same percentage. We have 16% of new cases they are prostate cancer. And as you know, to follow up and to diagnose prostate cancer early is very important, because the survival and the quality of life of prostate cancer patient is related to the stage of disease. As you can see here, if you have local and even regional metastasis, the survival for 5 years is 100%, but this decreased to 28% if we have distant metastasis. And multiple studies show that about 90% of men who die of prostate cancer have bone metastasis. So it's very important to have a good staging for prostate cancer. They are the current clinical problem in prostate cancer worldwide, not only in Lebanon. It's to detect the tumor in patients with a rising PSA and negative biopsy, especially in young patients, localization of tumors within the prostate, localization of recurrence in patients with biochemical failure, and rising of PSA after curative treatment, accurate detection of metastatic disease at an early stage, especially in the personalized medicine era, to treat every lesion and to give better survival quality of life of patient. For the patient, determining early therapeutic response to treatment with high accuracy. So we have a lot of radiotracer used and can be used in prostate cancer. We have metabolic radiotracers such as fluorocholine and flucyclovine, and we have receptorial radiotracer such as gallium-68 PSMA ligands and F18 PSMA ligands. And of course, we have a lot of radiotracer, but we will focus for our experience in gallium PSMA. We have a small experience with F18 choline for 2-3 years, but we shifted completely to gallium-68 after that. As you know, prostate-specific membrane antigen is a cell surface protein. It's a glutamate carboxypeptidase 2 protein, can increase the expression in prostate cancer cells if compared to the other physiological PSMA uptake. And we know we have a PSMA, physiological PSMA expression in normal tissue such as kidneys, proximal small and bowel, and the salivary glands. And of course, we have lesser uptake within the liver and with the spleen also, excuse me. So this, excuse me. Oh, okay. I don't know what is the problem. Yes. So this is excuse me. I don't know what is the problem exactly, but Okay, this is a real life of prostate cancer. In this previous picture, prostate cancer. So start with diagnosis, then with the treatment, and we know we have recurrent disease in some patient, and this disease can be treated many times by hormonal therapy after radical surgery, and or by chemotherapy if we have distant metastasis. But we know the risk to have recurrent metastatic disease is high, and we need, of course, a new treatment, and we'll talk later about the new modality, I mean lutetium PSMA. Many work try to find the role of PET PSMA to detect primary disease within the prostate cancer, and found that the sensitivity is limited to 67% because we cannot detect smaller lesion, and sometimes we have a false negative related to the grade of the disease, I mean Gleason score, and which decrease our sensitivity. The specificity is acceptable, it's 92%, with accuracy 72%. So also, I don't know why. You can see the screen.
Yes.
Okay. So many. Don't know what is the problem. Okay. Many work also compare the PET CT scan to MRI and show that sometimes PET CT scan can detect unsuspected lesion on MRI, and also can increase the confidence to the physician to tell this lesion is malignant. So we can see in this graph, it's not about MRI or PET, it's to complete the information from MRI and PET to have better information and good result to detect small lesion especially, and to help physician for some what is the problem? To help physician to biopsy the lesion, to direct the biopsy. So at our institution at the American University of Beirut, we decide to do a study about the role of PET CT in comparison with MRI and histology, but we decide to take the 36 segments in comparison to MRI, and to the histology also segmented the prostate to 36 segments. In the literature, we know we took normally 8 segments only, and our aim was to compare that with the literature to see if we take smaller segments can increase the sensitivity and specificity of the exam. So we took 23 patients, a total of 28 regions have been examined on both PET CT scan and histology. Most of them were intermediate risk and high risk patients. 17 patients were Gleason 7, and with extraprostatic extension, and after a surgical margin was involved in 6 patients and not involved in 17 patients. And we can see an example of comparison between PET CT and histology. In this example, we have significant uptake of the prostatic gland in keeping with malignant disease, with histology positive, completely positive. The other lesion is positive on PET CT, negative, and histology. The third one is completely negative. We have heterogeneous uptake, but diffuse, not specific in PET-CT, but histology detect 2 millimeter focus of prostate cancer. So I will show you directly an example, MRI case of patient operated in 2017, PSA 7.54, glycine score 8. With the right robe, you can see MRI is showing a lesion within the right lobe, positive on PET-CT, but it was very important, the detection of this small lymph node in the perirectal region. Histology detect one confirms the lesion margin was negative, and one the lymph node was positive with microfocus 2 millimeter. Another example, MRI show a heterogeneous lesion ill-defined. You can see highly suspicious for malignant disease, positive on histology, positive in PET-CT, and with no evidence of regional metastasis. Surgery shows that lymph node dissection negative, lymph node 0 out of 24, and the classification was PT3A with focal disease. Multiple studies, excuse me. There's a problem with the internet, excuse me. So multiple studies shows that if you take the index lesion, the sensitivity can be between 67 and 81. For our result for index lesion, sensitivity was 68%, and for specificity was 98% for index lesion. If we took the 36 segment, and you can see here our positive predictive value was 83, negative predictive value 96, with accuracy at 67, and as I mentioned, with good specificity. Our result is almost similar, so there is no benefit from 36.7 in comparison to 36 segment in comparison to 8 segments. So PET-CT can be helpful to localize the index lesion, and can have a important role before surgery. Second work in our institution was to detect the prostate lesion and to see if the early PET-CT imaging can be helpful to detect the local disease in the site of the prostate bed or in the prostate by itself. And it was a retrospective study to 47 patients. We took the early image of the pelvis, obtained either every minute for the first 5 minutes or every 3 minutes for the first 6 minutes. After that, we have whole body scan, and we correlate the early image with the late image. So as I mentioned, we included 247 patients, 80 patients excluded because no early imaging performed. Early image and late image performed only in 167 patients. 79 were for primary staging, and 88 for assessment of recurrence. In our result, we found that we have 8 patients out of 167. We found pathological uptake was detected only on early imaging and was masked by bladder activity at 60 minutes. So I will show you some image. So this is the early image. You can see we have this high uptake within the prostate bed, and you can see the uptake within the vessels related to early acquisition. At the 60 minutes, you can see it's very hard to see the lesion because we have high uptake within the bladder. Another example for patient after radical prostatectomy, we have rising of PSA. The early image show also another lesion with the prostate bed, very high, and at the early image, this lesion, it was very hard to see it because it was we had the diverticulum, and it was very hard to differentiate between the lesion and the physiological uptake. And we conclude that early imaging can be helpful and can increase detection of PSMA avid lesion suggestive of prostate cancer or its recurrence in the prostate bed, and this changing the management of this patient. This increase in detection is especially important in patients presenting for staging and it can be helpful to detect small lesion. I will take the opportunity also to highlight this work in collaboration between our region and the IAEA. This publication, this work published in July 2021. It's about the role of PET PSMA to detect early to detect the site of relapse in early relapse prostate cancer after radical therapy. Dr. Akram Al-Ibrahimi also was with us with this study, and this study included recruited from 17 centers in 15 countries. Inclusion encompassed histology, histopathology, proven prostate adenocarcinoma with previous primary treatment and clinical established biochemical recurrence with serum PSA below 4 nanogram per milliliter or below 10 nanogram per milliliter with negative MRI and bone scan. So in this study, we had 1,004 patients from 50 countries, as I mentioned, and you can see that the impact of PET PSMA result in clinical management in most cases was superior to 55%. It was almost 57%. And you can see in this study, PET PSMA can be helpful, and the sensitivity increased with the Gleason score as well as with the PSA level. So it's very important now to correlate the Gleason score and PSA level before starting PET PSMA study. And also we can see the sensitivity can increase from 60 to almost 87% from Gleason score 7 to 10. And in this paper we had many examples. I will show you negative examples. So first one, there is no evidence of recurrent disease. The treatment plan was not altered by PET CT scan because we didn't find any lesion. So treatment is local radiotherapy to the pelvis. And the second example, we found lymph node metastasis in the iliac region, and the treatment was modified from radiotherapy to hormonotherapy. And third example, we detected the distant metastasis. We can see in the whole body we have multiple lesions within the bone and also lesion within the lymph node. So treatment plan was modified from radiotherapy to chemotherapy. So as conclusions, this multi-center international prospective trial confirmed its capability in detecting local and metastatic recurrence in most prostate cancer patients in the setting of biochemical recurrence. And PET PSMA positivity was correlated, as I mentioned, with Gleason score and PSA PET, as well as PSA doubling time and the radiotherapy as primary treatment. And the result led to changes in therapeutic management in more than half, I mentioned, almost 57% of patients. So we conclude that this technique is very helpful for the patient. What about the treatment for prostate cancer? We started the treatment in Lebanon in 2016 with lutetium PSMAs, and we included 2 years after that actinium, especially for the patient resistant to lutetium. So now, as I mentioned, in 2016, we started the lutetium. We included in this work our patients from 2016 till June 2020, treated by lutetium PSMA. Some of patients received second line by actinium 225. Our protocol was to perform the PSMA before treatment for patient. The treatment, it was a 4 cycle with dose between 150 to 200 millicurie every 8 to 12 weeks, followed by SPECT CT at 48 hours or 72 hours later. Follow up by PSA and PET CT scan after cycle 2 and at the end of treatment. Some patients received only 2 doses due to the economic situation of the patient, because this treatment is not covered now in Lebanon, and the patient need to pay from his pocket money. And if no response after 2 cycles of lutetium, treatment by second line with actinium started. I will show you some example. Patient 1, patient 75 year, diagnosed in 2009 with prostate cancer. Had radical prostatectomy treated by hormonal and chemotherapy, but PSA increased under treatment. PSA level was 370 nanogram per deciliter when he was addressed to our department. And this patient received only 2 cycles of treatment. And you can see before treatment we had diffuse bone metastasis. After 1 cycle, we started with 150s and shifted to 195 millicurie, and we have significant decrease in the uptake, but a complete remission not achieved because the patient stopped the treatment. Another patient, 82-year-old male with metastatic castrate-resistant prostate cancer to lymph nodes and bone, treated by hormone therapy and chemotherapy. PSA level was 210. Started in July 2017. We started PSMA. We had diffuse bone metastasis. In February and May 2018, we started treatment by lutetium. He received 2 cycles of lutetium. We can see we have some decrease in uptake in some area, but not so important. So at this time, we discussed with the patient to shift to actinium, but he cannot afford the price. So we start complete by 3rd dose of lutetium. You can see we have decrease in activity and some lesion. So we shifted to actinium in January 2019, and the patient received 2 doses. After that, we have good response to treatment. And PSA in July 2019 was PSA 2.5, and the patient last seen in June 2021, and PSA was 1.8 nanogram per deciliter. Third patient, similar, treated, but was treated by hormone therapy and chemotherapy, not responding. We have the multiple site of bone metastasis with liver lesions. You can see it here. So treated also by docetaxel plus zoledronic acid, tolerated with dose reduction to 60 milligram per millimeter square. PSA response and pain improved, but the patient continue to rise the PSA level. So with the recurrence of bone pain, so we decided to go for lutetium. After 2 cycles, we can see we have partial response. After 3rd cycle, we had a good response to treatment. The patient came after the last treatment in January 2020 with lesion in the right ear detected as melanoma by histology, and so the patient was treated operated for the melanoma, and last year in June 2021, PSA level was 198 with no bone pain. So, and he is now free from melanoma disease, but still have some lesions from prostate cancer. So, to summarize, from our experience, we think that early images could help to localize prostate lesion or detect local recurrence. PSMA can be useful for therapy monitoring to localize recurrent metastatic disease and change in management and patient selection for PRRT. Our experience with lutetium ligand therapy demonstrate promising treatment in the region. It's an option in metastatic cassette-resistant prostate cancer with a low toxicity profile. Thank you very much.
Thank you, Dr. Mohammad, for this comprehensive overview of the current status of PSMA theranostic and the prostate theranostic in Lebanon. Actually, now in the first session, we would have 4 talks, and all participants, they can post their questions in the chat for the question and answers. And at the end of the first session, when we finish the first 4 talks, speakers will kindly answer all the questions posted in the Q&A section. Dr. Khaled, please. Now, my co-moderator will continue now.
Bismillah ar-Rahman ar-Rahim. Next, I have the pleasure to introduce our colleague, Dr. Batool Albalooshi from United Arab Emirates. I have heard about her a lot, and now her turn to introduce their experience about Teranastics in her country. Please, Dr. Batool, welcome.
Thank you, Dr. Khaled. First of all, I would like to thank the authorities at World Federation, respected Professor Jean-Luc, President of Arab Society, Dr. Mohammad Haider, past President, Dr. Akram, and all my colleagues in the society and our audience who made this event happen. And I hope that our experience will serve other colleagues everywhere to start or to continue with their effort to help patients with use of theranostic for diagnosis and therapy. And I have started all my services from 0 level, so I hope that I will be a model to my younger colleague can use this experience and start their own services. I will share all that I had challenges and all circumstances that we can overcome and start such services to help our patients. First of all, United Arab Emirates consists of 7 emirates, and roughly a population of 10 million are distributed among 7 emirates, with the most populated emirates, Dubai, which is hosting about 5 to 6 million of their population. I have spoken about the population, and I can say that UAE is a metropolitan country with a heterogeneous population, and in terms of cancer detection and follow-up and researches, it made it really a difficult task for us to follow up sometimes or to establish a study, because this is a business hub and people are coming and going from UAE, but whenever it's possible, we are catching the trends and trying to make our publication and studies in cancer. So, can I go to the next slide, or shall I do my share screen also? Okay. Cancer overview in UAE. So according to the reporting data from national cancer registries in UAE, approximately 4,500 new cases, 4,500 new cases of cancer are reported in a year, which means 12 new cancer cases a day, and 28% of those are from the local population from Emirates, and 72% among expatriate residents. I forgot to mention that from the 10 million population, 9 million are the expat resident, and about 1 million are the local population, which when divided to 7 Emirates, it's a small number. So this made the cancer the third leading cause of death in UAE, accounting for 13% of fatalities. According to released reports in UAE, top 5 cancers in males are leukemia, colorectal cancer, prostate cancer, non-Hodgkin lymphoma, and brain cancer. And in female, top 5 cancers are breast, leukemia, colorectal, thyroid, and uterus. Okay. History of nuclear medicine in Emirates. First nuclear medicine department was established in late 70s in capital city of United Arab Emirates in Abu Dhabi. And first radioactive iodine services for treatment of thyroid diseases started in early 80s at Dubai Health Authority. Dubai Health Authority is the main health authority for the government of Dubai, and each Emirates, it has their own government and their own health system. So for Dubai, it's the largest and I can say the most active health authority within Dubai government. And the first cyclotron was commissioned in Dubai in 2007 for a private hospital for production of FDG, and accordingly, first PET CT service started on the same year. Currently, there are roughly 15 nuclear medicine centers in the UAE and 3 cyclotrons, which are serving all nuclear medicine centers with molecular imaging facilities. Some of these centers having advanced nuclear medicine, molecular imaging, and radionuclide therapy services, and some are basic. Due to logistic issues and regulatory requirements, only few centers are providing radionuclide therapy services. Okay. This is a view of Dubai Nuclear Medicine and Molecular Imaging Center at Dubai Health Authority. This is where I work. I'm founder of molecular imaging at Dubai Health Authority, and we work very hard to also establish other services, which I will mention. And the practice of Theranostic in oncology made a beginning in 1980 when Dubai Health Authority at DHA became the first institution within UAE to use radioactive iodine for the treatment of thyroid cancer. This has now grown to a 5-bed isolation ward and is the largest radionuclide treatment facility in the country. Dubai Health Authority has also been treating neuroendocrine tumors with lutetium dotatate since 2017 and prostate cancer with lutetium PSMS since 2018, at the end of 2018. We also established iodine-131 MIBG therapy for neuroblastoma and malignant pheochromocytoma as well. For Theranostic in management of thyroid cancer, we use Theranostic for well-differentiated thyroid cancer with radioactive iodine has been well established and is being regularly performed in UAE for remnant ablation and as adjuvant and treatment of metastatic disease. Since we are getting our radioiodine from overseas, the ordering process a little bit a long procedure, and it starts when we get the referred patient from outside or within our hospitals in Dubai Health Authority. Then we put the order of the radioiodine, and we have to get the national regulatory authorities approvals. And when we get the approvals, then the order is sent through our local supplier to abroad to their own manufacturer, and we receive a calibrated iodine 131 as per our order, and total order and delivery process will take usually 7 working days and more in case of public holidays in Europe. If we have difficulty during the Christmas and New Year's when we get it very late, so usually we recommend and avoid therapies in December. So we refer them to other centers which can afford that for that time. So the overall number of patients with thyroid carcinoma treated in our hospital only in Dubai Health Authority between 2014 and 2020, total were 2,350, 12 were male and the rest about 2,342 female. And as very well known, the most diagnosed cases, 86% were papillary thyroid cancer and 14% follicular thyroid cancer. Management of well-differentiated thyroid carcinoma in UAE is usually the responsibility of a multidisciplinary medical, surgical, and diagnostic team, and treatment modalities usually include surgery, radioactive iodine ablation, external beam radiotherapy, hormonal suppressive treatment, or combination. Surgery is the treatment of choice for well-differentiated thyroid cancer in the United Arab Emirates, followed by radioiodine ablation. Some theranostic cases that just to show. We do, as I said, after the total thyroidectomy, ablation of the remnant. This is a 39 years old lady with history of total thyroidectomy, right modified radical neck dissection in 2020, in November 2020, for multifocal papillary carcinoma of thyroid with lymphatic invasion, and 3 out of 21 lymph nodes were positive, and there was no extrathyroidal extension. As you see, she was here in 2020, 21, she was ablated, and her thyroglobulin at the time of ablation was 2.76 nanogram per ml, and she had a remnant of thyroid tissue in the thyroid bed. And this is 6 months after the ablation. She came with her thyroglobulin declined, and her remnant vanished. So this is a example of a successful ablation of the thyroid remnant. Not all thyroid cases are very well at the beginning, and this unfortunate male came to us with paraparesis, and he was already diagnosed with the metastatic disease, and the surgeons, they didn't know what to do, and they sent the patient to us with the whole thyroid in the neck and with the whole metastasis, and they told us to manage this patient. We sent him back and we advised for thyroidectomy, and after thyroidectomy, this patient, who is 57 years old male and metastatic follicular cancer, he came to us with thyroglobulin more than 5,000, and we ablated him with 250 millicurie iodine 131, and he's coming in January for his follow-up scan, and I hope it will be better than this. This patient, because we at Dubai Health Authority started the first radioiodine treatments in early 80s, then we started for adult and children. So we treat also children, pediatric age group. This patient is very well known to us. She's 19 years old female currently. She presented first time when she was 13 years old. And at the time of diagnosis, she had bilateral lung metastasis and mediastinal lymph node and local remnant. So she was ablated in 2013 with 5,550 megabecquerel iodine 131, and then she came 3 times more for reablation, and through years we have reablated her, I believe, about 4 times, and she came in 2019 to us, and we did a diagnostic scan with 5 millicurie, and we were very happy to see that she is disease-free, her thyroglobulin under control, and she's coming on regular checkup to us. Another Teranastics that we started to do is the Lutetium PSMA therapy for prostate cancer management. In Dubai, the prostate cancer management consists of surgery, hormone therapy, chemotherapy, radiation, or Teranastics. The patient who are diagnosed with the prostate cancer, actually they have been managed between the urology and oncology teams at Dubai Health Authority. So it is the agreement that if the patient is prostate cancer with no metastasis, which is diagnosed in our department at nuclear medicine by F18 PSMA or by gallium-68 PSMA, and earlier with technetium PSMA when we started. So if the patient is metastatic free, it will be managed by urology team and they will proceed with hormone therapy. And if it is the metastatic disease, it will be referred to oncology team, and oncology usually with chemotherapy, radiation, and if all fail with hormone therapy, chemotherapy, and radiation, the patient will be sent to us for Teranastics. So for the molecular imaging or theranostic purposes, we used, as I mentioned in the beginning, when we didn't have the PET-CT, we started with technetium PSMA, and we also published a paper about technetium PSMA and gallium-68 PSMA, and we compared directly both methods, and we came to conclusion that PSMA, technetium PSMA also can be used for the staging and re-staging of the disease. So I believe that those colleagues or those institutions that they don't have PET-CT or they cannot afford the gallium PSMA, they can use technetium PSMA, and then they can proceed with lutetium therapy, PSMA therapy for their patients. So it is not mandatory, in my opinion, to have gallium PSMA to be able to help and treat patients. So we have, when we started the gallium PSMA in 2018, we have massively enrolled patients, and until now, maybe even over 500 patients were enrolled for gallium-68 PSMA between 2017 and 2020. From this selection, 10 patients underwent lutetium-177 PSMA, and beside these 10 patients, we had also few patients, and unfortunately, we were faced by COVID-19 pandemics, and those the doctors has to change the line of therapy due to delay in the radionuclide deliveries. However, from our 10 patients, 5 of them finished their 3rd cycle, 3 of them 2 cycles, and 2 of them 2 cycles. So this is a 66-year-old male with history of metastatic prostate adenocarcinoma, and he had metastasis in bone, liver, lymph nodes, and with Gleason score of 5+4. And this patient is one of our staff, and it was very sad to see him every day deteriorating. And when he was referred to us, we started his therapy, and after the 3rd cycle, we had an amazing result, and his all bone metastases are vanishing, and almost he is getting back to a very good quality of life due to his improvement, and also they did MRI for liver metastasis, and they are following up the liver metastasis, and they are also improved. And he has 2 more cycle, and we will see how it will go. So from the 5 patients, 3 of them had 5 patients had 3 cycles, and the result was that the PSA is declining, and they are due for 4 cycles. 3 patients, they had 2 cycles, and the PSA was rising, and of course clinically also they were in progress. So the lutetium therapy was discontinued, and other therapies were started for them. And 1 patient had 2 cycles and had progressive disease, and is for the tumor board discussion to discuss what else to be done for him. And 1 patient had 2 cycles, his PSA declined, and he had a very nice results, but the therapy was discontinued due to other comorbidities, and the patient was not able to continue the therapy. For neuroendocrine tumors, unfortunately, there is no statistics or any study to show the number or total number of neuroendocrine tumors in United Arab Emirates. However, roughly, I can say that we have, since 2017, that we have enrolled 120 patients with metastatic neuroendocrine tumor, and I can say these are the most of the diagnosed cases, because we are the only one at that time and until recently that we were doing this gallium dotatope PET CT. So this number is roughly accurate for people who are suffering from the neuroendocrine tumors. A number of patients who are enrolled for peptide receptor radionuclide therapy is limited. Limited due to, I believe that not all of them are recognized, or not all of them were referred to us or managed by our oncologists. And we have enrolled 2 patients successfully, and they have now completed their cycle, and they have controlled disease with declined chromogranin A level. And 2 are newly enrolled, and had so far 2 cycles. In fact, all our Teranastics services started in at the end of 2021, after the very good control of pandemics in United Arab Emirates, and by having vaccinated 95% of population. Now we have lots of freedom in hospitals, and many people are being referred to us for Teranastics. So this is one of our patients that successfully we treated for neuroendocrine tumor. This lady, 64 years old, and she had lots of complaint with nausea, vomiting, abdominal pain, and quality of her life was very low and bad, and she had lots of admission in the hospital. So she failed with sandostatin treatment, and she was referred to us, and we gave her the full treatment of dotatate, and her chromogranin from 294 declined to 120, and her clinical condition improved, and currently she is on sandostatin, and her disease is controlled, and on regular gallium gallium dotatope diagnostic scan follow-up. So as for every service or every diagnostic or therapy services in nuclear medicine, we have lots of challenges related to the place that we work or to the community that we are getting our patients. So I have highlighted few that it could be also applied to other regions or countries. So in UAE, most of patients are holding health insurance and some pay themselves the treatment. So when everyone or majority are holding insurance, that is a good news because the insurance companies will take care of their treatment, but it's bad for those that they are paying themselves. But we as a public hospital, we succeeded to keep the price of our services very low, so it is affordable for everyone, the therapy. The number of public hospitals which are offering Teranastics are low, and many private hospitals are not establishing the Teranostic services due to high cost or lack of human resources. And the use of other Teranostic form of treatments are progressing, but very slowly. However, the induction of such therapies needs more engagement of health institutions and health insurance companies to take part in implementation of such therapies and even to cover the cost of therapy. And task for improvement, I believe it is very important to induce awareness among clinicians and referring physicians about when to send the patient. I get usually very frequently many patients that they are unfortunately not even fit for Theranostic and they are in very late stage, and I believe that we could help them in an earlier stages. So awareness among the referring physician is very important. Conclusion, in summary, Theranostic pathway in UAE is on the right track, and it is only a matter of time when we will be able to overcome the constraints and put this form of treatment to optimal use in a larger number of patients. We are trying to promote Theranostic by learning and practicing to gain experience. When we started in 2018 until now, we have conducted 4 international conferences and symposiums for United Arab Emirates and the countries in the region and also international, and to open opportunity for them to gain knowledge and experience and to help patients. And inducing awareness among clinician and patient selection appear to be a key factor and play a very important role in increasing Theranostic for patients management and favorable outcome for patients. In our observation, we have shown that Theranostic practice is feasible at our site, however, with few challenges, mainly related to awareness of the other specialists and their on-time referral for such therapies. Lack of trained radiopharmacists also contributed to limited centers who are offering Theranostic. The external resources for supply of lutetium during the COVID-19 pandemics were reliable to provide us with needed doses. However, due to lack of regular flights, therapies were delayed in some occasions, which made the referring physician to change the line of therapy. I would like to thank you and invite you all to visit us in Dubai Expo 2020, which was delayed to 2021, now is going on. And I invite everyone, all audience who see us here to come and visit us. Thank you.
Thank you very much, Dr. Batool. A very nice talk, and I am so impressed by all these activities you have guided. Thank you. Dr. Akram.
Yes, thank you, Dr. Khaled, and thank you, Dr. Batool, so much. Our next speaker for this session is Dr. Alain Abi-Ghanem, and he is a nuclear medicine and radiologist at the American University of Beirut. He's associate professor, assistant professor for nuclear medicine and clinical radiology, and Dr. Alain will be talking about the current challenges in theranostic perspective of a nuclear medicine physicians. Please, Dr. Alain, the floor is yours.
Thank you, Dr. Ibrahim. Good evening, everyone. Thank you for staying late. I'm actually very honored to be sitting on this panel between physicians who keep working hard to advance nuclear medicine in the Arab world. So thank you for all your work and all your effort for doing this. So today I will talk about the current challenges in theranostics, my perspective of a nuclear medicine physician. Why this is challenging? Because we have too many cooks, so many parties are involved. As you notice, oncologists, surgeons, radiation safety, nuclear medicine physicians, sometimes interventional radiologists are involved in these treatments, radiation oncologists, pathologists, gastroenterologists, and endocrinologists. So they are all involved in the treatment of these patients who either have thyroid cancer or prostate cancer or neuroendocrine tumor. So it's very important to coordinate between all these cooks in order to get the right recipe and benefit the patient for his or her treatment. So what comes to my mind when I think of challenges? First of all, the science. So we need to validate these treatments in prospective randomized trials. So the work has already started, but we need to wait for further data to come, for further results. We have noticed so far variable response rates due to tumor heterogeneity. So it's kind of embarrassing because sometimes we ask the patient, or the patient asks us, so what are my response rates? And let's say we give them 20% or 30%, and either they don't respond at all, or sometimes they do respond. So it's very heterogeneous so far because we still don't know all the genomics or all the characteristics of the tumors of these patients. So it is challenging. Limited availability is also a challenge that comes to my mind. We have to be aware of the appropriate indications. We have to be aware of the appropriate treatment protocol and how do we deliver that. There's always this drama around radioactivity, especially in the Arab world, that this is something kind of a taboo, or there's a stigma around patients who receive radioactivity. So our job as nuclear medicine physician is to simplify the treatment and decrease this anxiety and this tension around this patient who received these treatments. There's also a very important challenge, which is the financial coverage. Dr. Albalooshi mentioned at the end of her talk about who's going to pay for these treatments. And obviously, those who are lucky are those who are covered by third-party payers. Logistics. So we have to know the logistics, who delivers these treatment, how do we order these medications from the, let's say, from the nuclear reactors, from suppliers. What are the tests that we need to do before and after the treatment? How do we transport the dose? How do we infuse the amino acids? Again, how do we deliver the dose? Do we use a pump? Do we give an IV push? What are the room requirements if we need to admit a patient? Do we have to have a shielded room? Or it can be a regular room on the floor? Is overnight stay to the hospital required? Who admits them? Do we as nuclear medicine physicians admit these patients, or our colleagues on oncology or endocrinology? So we have to be aware of these questions. And who does the follow-up? So after we give our treatment, so who's responsible? Who does the follow-up? And finally, how do we manage the waste that we generate from delivering these treatments? So how do we deal with the tubings that we remove after administering these treatments? Okay, so case one, very simple. I'm going to start with lutetium PSMA treatments. Mr. RA is a 66-year-old man with metastatic castrate-resistant prostate cancer who is being treated at our hospital with lutetium PSMA. On the day of the second cycle, he reported marked improvement in his bone pain after the first cycle. So these are the emission scans obtained 4 days after delivery of the lutetium therapy. So you can notice the whole body scan done after the first dose. We have multiple bone metastases as well as several metastases in the liver. After the second dose of the therapy, we notice a significant improvement in this patient in the bone metastases as well as improvement in the hepatic metastases. So lutetium PSMA has been accepted and granted priority review by the FDA at the end of September, last September, for the treatment of metastatic castration-resistant prostate cancer in the post-androgen receptor pathway inhibition, post-taxane-based chemotherapy setting, and this is based on the VISION trial that was published in the New England Journal of Medicine in September 2021. Of course, we don't wait for the FDA to actually start giving these therapies. The European Association of Nuclear Medicine also did not wait and issued actually procedure guidelines 2 years before that. So what comes to mind, again, when talking about the challenges? Limited availability, I can speak of my experience in Lebanon. These are mainly available at our institution at AUBMC. Few cases have been done at Mount Lebanon Hospital. As far as the indications, lutetium PSMA is indicated in metastatic castrate-resistant prostate cancer, in cases of progressive disease, and in cases with adequate uptake of PSMA ligand on a pre-therapy imaging PET scan. What is the treatment protocol? So we usually administer around 200 millicurie per injection, 2 to 6 cycles, depending on the response, depending on the prognosis and the renal risk factors. So if the patient has a preserved renal function, we can go up to 6 doses. And we deliver our cycles or our injections at 6 to 8 weeks interval. With regards to the drama around the radioactivity, again, we tend to simplify the process in front of the patient. As far as us nuclear medicine physicians, we have to be aware of certain physical characteristics of the lutetium. So we have to know that the half-life is around 6.7 days, that it has a beta emission of around 500 keV and a gamma emission of around 210 keV, and that the range of the beta emission is around 1.5 millimeter. So we have to know these physical characteristics in order to ponder our terms when talking in front of the patient, when trying to reassure him and trying to give him radiation precautions after being discharged and going home with his family. What are the excluded patients? Who are the excluded patients and what are the contraindications? So in patients who have liver metastases that are negative on PSMA PET, we don't give lutetium. Those who have a life expectancy of less than 6 months, those who have unmanageable urinary tract obstruction or hydronephrosis, and those who have progressive deterioration of organ function, whether we're talking about renal function or liver function, and finally, those who have myelosuppression. So these are basically, we want a stable patient coming to our department. Of course, we're not going to treat someone who has renal failure who is on dialysis. We're not going to treat someone who has severely elevated SGOT or SGPT. And of course, we're not treating a patient who has platelets of 20,000 or a white count or barely neutropenia patient. So we have to be, we have to return to the mind of a clinician. So move away from diagnostics, from radiologist or from an imager, and we have to go back to thinking of a clinician, basically. So these I would say criteria, exclusion criteria, make sense. With regards to the treatment itself, so it's usually a well-tolerated treatment, very minor side effects, usually 30% complain of dry mouth, and around a quarter of the patients are fatigued. Marrow toxicity is usually due to innocent bystander effect rather than direct effect on the marrow, and it's usually a low-grade reduction in hemoglobin and platelets. So with this in mind, we understand why we have to monitor the patient after delivering our dose by measuring their CBC every 2 to 3 weeks, for example, after the cycle. There has not been any clinical interaction studies for drug-to-drug interactions. And also to avoid additive effects on bone marrow suppression, external beam radiation therapy, chemotherapy, and any radioactive bone seekers should be discontinued for at least 4 weeks prior to the treatment. Now, this is the big challenge, financial coverage. Usually they are paid by the patient, even here in Lebanon. Some insurance companies, however, have started covering the expenses. And to give you an idea about the prices in Lebanon, so a dose of 200 millicurie is around $7,000. It ranges between $7,000 to $10,000. The $10,000 is the dose that comes carrier-free. And if you see these prices in comparison of the usual chemotherapy, for example, a dose of docetaxel is 1,000 per cycle. Enzalutamide is 4,000 per cycle per month. Abiraterone is around 4,000. And also, these are covered by third-party payers. So we're kind of fighting an unequal war with our colleagues in oncology. So their medications are covered by third-party payers, whereas our medication is not. Okay, so how do we prepare the patients? Ahead of time, we need to have a gallium PSMA PET-CT basically showing uptake on the PET scan. We have to have a PSA level, a baseline PSA level. We measure a baseline cell blood count, creatinine, BUN, liver function test. During the treatment, the value of cold packs is still controversial on the salivary glands. There are some theories that this could reduce the toxicity of mouth dryness, but this is still controversial and it's actually still being evaluated. Concerning corticosteroids, they are mandatory if there are cerebral, spinal, or other metastases with risk of painful or obstructive swelling. So we have to give steroids in these situations. Of course, whenever we have a severely or an advanced metastatic patient presenting to our clinic, we always coordinate with the oncologist, and we can always ask for help in delivering these doses ahead of time. Logistics, so who delivers them? So the radiochemist is involved, the nuclear medicine is involved. We have to have a nuclear medicine technician who is trained, also a registered nurse, also trained in dealing with radioactive material. And we should always have the radiation safety personnel with us when we deliver these treatments. How do we transport the dose? So it has to come in a syringe shield placed in a lead peg, and we carry this on a shielded trolley to the room where the patient is actually located. Lutetium is delivered over 30 to 60 seconds, slow IV infusion in a pump. So of course, we don't recommend holding the syringe in our hand and delivering it slowly by hand. So because obviously we'll be radiating ourselves. So it has to be housed in a special pump. We have to know how to use the pump. We have to make sure that the tubings are not leaking and they are well connected. We hydrate with saline before and after, and we make sure that we are flushing after the treatment with saline. And again, I mentioned that the use of cold packs over the salivary glands is still controversial, but we can still give it, it doesn't harm. So again, always check for the IV access, whether it's functioning, check the connections of the tubing, the saline bag attached to three-way in order to flush properly and maintain a closed system without having to disconnect the tubing. The patient is actually in a separate room. No need for shielded room as in iodine treatment. So it can be any room separate, and of course, no patient should be sitting next to the, usually it's a single bedroom. This is what I meant actually. It's a single bed room. Is overnight stay to the hospital required? No, it can be done as a one-day procedures at AUB, who admits oncologist or nuclear medicine physician. We're working actually on getting privileges to admit these patients, but until now, and that's going to happen very soon, until now, the oncologist is the one who is responsible for the admission. And they actually consult us for delivering the dose. Who does the follow-up? We both do the follow-up. So us, nuclear medicine physicians, and the oncologist. As far as waste management, radiation safety monitors the room and the toilet. They collect absorbent paper and tubing in radio-labeled bags, and they store them for decay to background if they are contaminated. Otherwise, they just discard them with the regular waste of the hospital. As far as follow-up, every 2 to 3 weeks, we do a CBC. Every 6 to 8 weeks, we can actually do LFTs and creatinine measurement. Every cycle, we measure the PSA, and we can do the post-therapeutic emission scan after the treatment. At our institution, our emission scan is done 4 days after delivering the dose, and we do a whole body scintigraphy, similar to the one that I showed you earlier on the case. And every 2 cycles, so every 2 treatments, we can repeat the gallium PET-CT. So as far as response, at least 30% of patients have no response or delayed response after radioligand therapy. The effect of the pre-RLT treatment and characteristics of lesions are basically a potential factor for limiting the efficacy, because we don't know what the patient received early on in his treatments. And of course, other limitations are related to the tumor grade. The higher the grade, the higher the Gleason, the bigger the tumor burden, basically the chance to have a response decreases. And finally, PSMA heterogeneity and DNA repair defects affect the response rate. Okay, so for the future in lutetium PSMA treatments, the use in early prostate cancer rather than as a complementary treatment after ineffective chemical therapy is effective. I would say is needed. So studies in this regard are helpful. More prospective comparative trials are still needed to discuss and improve its efficacy and standard of care. Actinium targeted alpha therapy. So actinium PSMA as an escalation step in case of resistance to lutetium. That's also in the future in the pipeline, and we started doing few cases of actinium here at AUB. We have to study the combination therapy between different nuclide radiation. That's also that needs to be explored in the future. And as far as protection from side effects, so kidney and salivary gland protection, there are studies basically assessing the botulinum toxin, 2-PMPA, mannitol, and ice packs. Okay, moving on to lutetium dotatate for neuroendocrine tumor therapy. Mr. AK is a 52-year-old man with metastatic pancreatic neuroendocrine tumor. Whole body scintigraphy images after the first dose. You can see the primary lesion in the pancreatic head and multiple metastases, radiotracer avid metastases in the liver. After the second dose, we have an improvement. So we have some partial response, and the gallium DOTATOC PET-CT done 6 weeks later shows a decrease in the tumor burden. Also, the European Association of Nuclear Medicine, the IAEA, and the Society of Nuclear Medicine and Molecular Imaging issued practice guidance or practice guidelines in 2013 for the treatments in neuroendocrine tumors. Basically, I'll go to the challenges. So to our knowledge only at the UB in Lebanon, as far as the indications, so these are given for well or moderately differentiated WHO grade 1 or 2 neuroendocrine tumors. So these are defined by a Chi-67 level of less than 20%. Of course, we treat patients who have positive expression of somatostatin receptor 2 and those who are metastatic or inoperable neuroendocrine tumors. How do we assess before the treatment? So we have to do a pregnancy test. We have to make sure that this patient is not neutropenic, doesn't have low platelets. So these are the thresholds that we keep in mind. Creatinine, so renal function has to be good. Creatinine less than 1.7 milligram per deciliter. We have to get a set of liver function tests if we know that the patient has a heavy tumor burden in the liver. And again, the Ki-67 should be less than 20%. Of course, we have to have a gallium DOTA-TOC PET-CT to make sure that these patients, these lesions are actually radiotracer avid. With regards to the protocol, the dose is also around 200 millicurie, 4 to 5 cycles delivered usually every 8 weeks, so 6 to 12 weeks. So pretty much similar than lutetium PSMA. Same thing, be aware of the physical characteristics of lutetium-177. With what makes it different than the PSMA treatment, these in the neuroendocrine therapy, in the DOTA-TATE therapy, we can observe a mild allergic reaction secondary to the amino acid infusion. Why do we give the amino acids? Because lutetium DOTA-TATE compounds can have some renal toxicity. In fact, we can observe around 4% loss of the clearance of the creatinine per year, despite renal protection. So the amino acid help decrease this risk. And we have observed a marrow toxicity that is actually more severe than PSMA treatments. So here we have grade 3 to 4 marrow toxicity in a small number of patients, but these are mostly reversible, so that's also reassuring. And sporadic cases of myelodysplasia or AML have been reported. So lutetium DOTA-TATE is slightly more serious than lutetium PSMA. We have to watch for functional syndrome, so carcinoid syndrome, hypertension, hypoglycemia, hypergastronemia, hypertension, and we have to be ready to treat if needed. So when I'm giving lutetium DOTA-TATE, I would, I say it, I have to be around. So I don't, we don't deliver the dose and leave and go back to our department. So we have to stay around and watch for these side effects in case they occur. And we have to be ready and familiar to intervene. Financial coverage, again, they're mostly paid by the patient. The price is around of 200 millicuries is pretty much the same thing. Slightly more expensive than the PSMA. These range between $8,500 to $11,000. But fortunately, some insurance companies in Lebanon have started covering the treatment costs. So who delivers them? Pretty much the same thing. Radiochemist has to be around, nuclear medicine physician, trained nuclear medicine technician, trained radiation registered nurse, and the radiation safety personnel has to be on board. Tests before and after the treatment, I already mentioned them. We have to withdraw the sandostatin, so the somatostatin analogs, whether it's long-acting or short-acting, ahead of time. We could deliver antiemetics, Zofran, plus minus steroids before the treatment. With regards to the amino acid infusion, we preferred a solution of lysine and arginine that is to be started 30 minutes prior to the delivery of the dose and continued a few hours after. And these burn, so when they actually pass through the vein, they burn the vein, so we have to watch for phlebitis. The dose is transported in a syringe shield, placed in a lead pig on a shielded trolley, and it is infused over 30 minutes. So PSMA, remember, is infused over 30 seconds. Here, it's infused over 30 minutes. Be familiar with the use of the pump. and hydrate well with saline before and after, and make sure to flush afterwards. Same thing, same precautions. Make sure that the IV access is working, the connections of the tubings are well sealed and there's no leakage, and the saline bag that we use for flushing and for hydration is connected to a three-way stopcock. Of course, monitor the vital signs, okay? Monitor the vital signs, especially watching for hypertension or hypotension. Room requirements, separate room, no need for shielded room, similar to the PSMA, and try not to dramatize. It can be done as a one-day procedure. Same thing, they are, oncologists are the ones who admit, and we're working on us being able to admit. We and the oncologist, we do the follow-up and we manage the waste the same way we manage the lutetium PSMA waste. So we monitor the room and the toilet, we collect on absorbent paper and tubing in radiolabeled bags, and we store them for decay to background if contaminated. So consensus still need to be made concerning the use of PRRT as a second-line treatment after non-radiolabeled somatostatin analogs for patients with non-resectable disseminated pancreatic neuroendocrine tumors. Also, patients with local but non-resectable primary disease, we have to decide whether PRRT should be used as a first or second line. What do we do with patients with grade 1 or grade 2 neuroendocrine tumors with mismatched lesions? So what do I mean by mismatched lesions? So those who have a positive FDG but a negative gallium. We still need to investigate the role of PRRT as a neoadjuvant treatment. And of course, validation studies are needed to confirm the benefits of combination treatments. Okay, moving on to microspheres, yttrium-90 microspheres. These are performed by interventional radiology. They are indicated for locally advanced primary and metastatic cancers with the metastasis to the liver, with the aim of maintaining.
Dr. Eren, we may finish in 2 minutes just for.
Yes, I'm at the end, Dr.
Thank you.
And also, they're indicated for HCC, so hepatocellular carcinoma, being downstage to receive potentially curative therapies. The cost is the main challenge, $21,000. And then we have to include the MAA technetium scan that we do a week ahead, it's $750, and the cost of the interventional radiology room and the catheters is still not included. So these are prohibitively expensive. For iodine-131, they are performed by endocrinologists and nuclear medicine physicians at our institution. The threshold or the cutoff to admit patients is 30 millicuries, and these are admitted to a shielded room. And we give them the instructions, and these patients are discharged at the dose rate at 1 meter is less than 5 microsievert per hour. The cost is around $500 for the imaging, for the whole body imaging after the treatment, and the dose itself costs around $3,500, including a one-night admission. Again, the indication, you're familiar with them, Graves' disease, toxic adenoma, well-differentiated thyroid cancer, and they are available in capsules or in solutions. And the contraindications, you have to be aware of them: pregnancy, breastfeeding, carcinoma with no iodine uptake, Graves' ophthalmopathy, severe thyrotoxicosis, vomiting, and diarrhea. So the suggested solution, it seems complicated because we have too many cooks, but the suggested solution is to create a theranostic unit to coordinate with different services and to bring these cases to a multidisciplinary tumor board to discuss and fight inside the tumor board. So this is actually a solution. So fighting here is a solution. And also we have to train our nurses and technicians in dealing with radioactive materials, because sometimes they get anxious that this is something magic that they are holding between their hands. But with little training, they become familiar and they can deal with these and streamline the process. And also, finally, we have to streamline the admission process and create a registry for patient outcomes. So finally, these theranostics are underutilized. There's limited knowledge and uncertainty regarding place in the treatment algorithm. There are issues about delivery, and there's a need for referral from other specialists. We have to be familiar with the logistics of the treatment. We have to pursue trials in upfront and combination therapy rather than last resort treatment, and we have to pursue validation in prospective randomized trials. So I would like to acknowledge Dr. Malak Shibai, our nuclear medicine fellow, our radiopharmacist, Nimar Naimi, senior technologist, Ya'ub Al-Bakki, and our teller, Muhammad Nasruddin. And these are my reference. I would like to highlight a very nice paper of Akram about peptide receptor radionuclide therapy, about PRRT in neuroendocrine tumors. With that, I conclude my talk. This is a view of our campus overlooking the Mediterranean Sea. So thank you very much.
Thank you, Dr. Aaron, for this very practical and very informative presentation, which is, I think, it would be very useful for all colleagues who are thinking to start theranostic treatment in their institution. Thank you so much. And Dr. Khaled would kindly introduce the next speaker.
And now I have the pleasure to present next speaker, our colleague from Kuwait, Dr. Fahad Marafi. Dr. Fahad Marafi, nuclear medicine consultant, president of Kuwait Society of Nuclear Medicine and Molecular Imaging, director of Gaber Al-Ahmed Center for Molecular Imaging, consultant in Kuwait Cancer Control Center, and member of the Kuwait Board of Nuclear Medicine. And his talk will be about molecular breast imaging. And I want to ask him to get some data for me, because my talk will share him this topic. Please, Dr. Fahd.
Good evening, dear audience. Thanks for the organizers, more especially Dr. Mohammad Haider. I hope you are hearing me clearly.
Yeah, very clear.
Okay, perfect. So the understanding of molecular breast imaging basically needs the understanding of knowing what are the components of molecular imaging. Many people are recently thinking that the only modality that is dominating in molecular imaging is nuclear medicine, but remember there are optical and fluorescence and a couple of other modalities where they compose the network of molecular imaging. But if we are planning to focus as nuclear medicine physicians on PET-CT and SPECT, then we have to tackle those examples. So before going through the main topic of molecular breast imaging and focusing specifically on breast-specific gamma imaging or positron imaging, we need to understand the cellular or the molecular level of a breast cancer cell. So we should know that there are many receptors, many targets, many cascades. And if we want to focus more on tracers, then we need to look at, are we targeting the estrogen or the hormonal pathway, or trastuzumab, which is Herceptin, or are we targeting metabolism like FDG? Then we are looking at glucose or glycolysis, or we are looking to target DNA. Then we are looking at fluorothymidine. And recently now they are using angiogenesis agents like fluorocyclicate or PSMA, or sometimes we are now reading about fibroblast activated proteins, or recently also integrins. So we are now tackling a breast cancer cell from a molecular perspective. So basically we have in radiology some meanings of radiology imaging, and now we are looking at a positron emission, what's the cascade happening, and then glucose and FDG, how the cells are taking those things, and now how we prepare the patient and look at those patients. sorry. So if we move forward, I don't know, it's just stuck a little. Yeah.
Dr. Fahad, do you hear me? We can't hear you now.
I think there is a technical problem. Dr. Fahd?
Yes, I can hear you.
Okay, could you continue, please? Would you please?
Yeah. So we're looking at now FDG fluoroestradiol, and that's the hormonal receptors imaging. And now we are looking at different kinds of pathways. So it's kind of slow in response.
Dr. Akram, could we ask for technical help?
Okay, can you hear my voice now?
Yes, now, Dr. Fahad, we can hear you, but it wasn't before a few seconds or minutes.
My apologies. Okay, my apologies.
Please, Dr. Fahad, you can continue.
So if we think of what's going on looking at metabolism, and FDG is a very good agent and being popularly used for staging and restaging and looking at response assessment, like this example, there is pleural metastasis and then is a good response after treatment. In Kuwait, since 2012 or 13, we have decided to push away methylene diphosphonates SPECT imaging, and we focused on sodium fluoride. Because of those reasons, rapid clearance, higher spatial resolution, we can use it in obese patients. And now if you look at a patient where we're comparing actual apple to orange, it's not tomo to PET, but again, the detectability, the sensitivity is superior in using sodium fluoride, and you look at the planar images of bone scans. When you move to obese subjects, you're looking at superiority using sodium fluoride, and we have published a good pilot study about it. Remember that an obese subject is a difficult case for being imaged under SPECT acquisition. Also, if we move to fluoroestradiol and you look at now estrogen receptor detection, and now the world is moving toward the new FDA-approved radiotracer. Now that's a clarification for patients who are responding and not responding. If we look at breast-specific imaging, we need to remember that there are gamma imaging, where we mimic mammography, and they like to call it in the industry molecular breast imaging, where we use either single or double gamma detectors or sodium iodide detectors or cellular detectors. Some of them, they come with biopsies. Some of them, they come without biopsy. If we move to PET imaging, then there is also positron emission mammography. Either you use it like stereotactic biopsy, the lady in prone position, and you put the breast in a well-shaped detectors, 360, so it's a clear-cut tomography, and you get no compression, unfortunately, and no biopsy. The Japanese company Shimadzu mimic the same thing with an elegant design, and you can see the resolution comparatively with a phantom, a phantom of a PEM and a PET. Chinese company called Chinese institute came in Chinese Academy of Science, and they produced PEMI. And also there is Shimadzu from sitting position. If you look at the lesions, they are really in superior clarity. And some researchers in my clinic, they invented something called PEM-CT, and they try to fuse the PEM images on the CT images. And recently from Sunny Brook Research Institute, they are trying to introduce a prototype of PEM mammography mixed together. I will focus only on my experience with PEM Flex Solo that has compression factor, I would say immobilization factor, not compression, and also biopsy feature. So we put the breast after fully preparing the patient for a dedicated breast imaging, or after a PET-CT. We inject the patient after following all the instruction with FDG, and we image the patient 60 to 90 minutes after the injection. And you look at a lady lying in the PET camera, how far we are from the lesion by approved by the phantoms, and look at breast immobilized or squeezed between two detectors, and you look at the resolution reaching 2 millimeters. And you look at the patient here with showing only some axillary uptake and the solitary lesion. But if you look at the image, you see the index mass lesion, and you see some satellite lesions. That's what we see also on this example. The molecular reason is that we can detect that early before we have some structural or vascular changes where MRI come in and also can show us good resolution. But we are an early detector modality using PEM. So look at the painless compression that has 1/3 compression of the mammogram, and you can still see clearly the medial side using MLO or a craniocodal. You can see also the image with the nipple in the profile, and you see clearly the fat plane and the dark side where that's the dark matter of the dense breast. See the resolution where you can see multiple lesions in this view, or if you go to mediolateral oblique view, you start with 12 slice like craniocodal. The first one is cranial, the last one is caudal. This one is, the first one medial, the last one is lateral. So you can get oriented with these lesions. So this is an MLO of a breast, and you can see as you move, like Thomas in the slice, you can see the superior resolution of the modality. And if you look at the mammography, you can tell that the mammography sometimes in dense breast or in some cases of implants is difficult to comprehend. Also, we can take an extra view of axillary tail, and that was negative scan, and this one is a positive scan of the axillary tail. Also, we use this to put the hand of the patient inside the detector for 2 to 5 minutes and see if there is any sort of filtration of the dose. Also, it's not qualitative, it's also quantitative. You take the mass lesion, you take the background, and you create a lesion to background ratio. Anything above 2, it's high risk for malignancy. Between 1.5 and 1.9 is moderate. Less than 1.5 likely to be inflammatory. Another advantage of having positron emission mammography is having a patient in a comfort position, no claustrophobia, no metal, no issue like MRI, and you go and you do the steps I'm showing now. You go with a target scan, you localize the tumor, then you go with a radioactive source, alignment scan, you take with the trocar the sample, and you scan that sample, make sure you are scanning the right sample tissue. Advantages of PEM are many, but the only disadvantage is ionizing radiation. If you look at the more disadvantages in MRI, there are lots of sensitivity, renal function issue, an expensive device, certain logistic issue like claustrophobia or metal objects. That's a very clear example where you can see the index lesion we agree about, it's in the right side and we know about it, but accidental left side lesion, when you look at the PEM had differentiated between 2 lesions on MRI. One of them is really genuine tumor, and the other one is falsely positive on MRI, negative on PEM, showing high-grade fibrocystic, low-grade fibrocystic changes. So PEM sometimes confirms MRI, sometimes contradict with MRIs. So many pathology confirmed findings used when you fuse the images, and in certain studies that started in 2011, it showed even little bit higher sensitivity than MRI. Not significant, but little bit higher. And the PEM has more specificity than breast MRI in 5% only, so that's not very significant, but we can say that sensitivity and sensitivity are comparable. So we can show many examples of pre-treatment, after-treatment, response assessment. You can use it even for post-treatment if you are suspecting recurrence or failure of response. This is an example of how you go for day 0, day 7, day 14. Now the consensus is to go for 2 months after chemotherapy cycles. Another example of early and delayed, sometimes when you are confused and you think this is not genuine or fibrocystic changes, you can use delayed PEM imaging after 120 minutes, like 2 hours post-injection. Just to get the flavor of PEM imaging, you can see that's a fatty breast. You don't see much of the dense breast, and you can see the index lesion. Sometimes you see it solitary, sometimes you see in different quadrant, and you change the surgery management. This is a reconstructed breast, mainly fat reconstruction, and you can see that there are really high superior clarities and sensitivities of those images, and you see a small index lesion. We saw large breast, and we can see now a small breast is still difficult technically, but again, we are there to do it. You can see even a large tumor reaching the skin, reaching around 8 centimeters, locally advanced tumor, multifocal, multicentric, with on MLO position, you can see the multicentricity and multifocality. For technical reasons, if we look at 1-minute image to do a fast scan, definitely a 10-minute scan is the optimum. Something in between depend on the cooperation of the patient. Again, another MLO, and you can see the difference between 5 minutes and 10 minutes. Definitely the 10 minutes is better, but you can live with 5 minutes if the patient is not cooperative. We had an accident of a patient who had a tumor during pregnancy and received the baseline before chemotherapy and for assessment of response. And we have scanned as a standard of the contralateral breast, and you can see the mammary gland with intense tissue uptake as physiological. Don't get surprised that we also can use it in male breast cancer if the patient is a little bit chubby, and we can still immobilize the breast under the detector, and you can see the index lesion. You can see the implants with 5 minutes, not 10 minutes imaging, and you can see the recurrence of the lesion under short acquisition, but very accurate acquisition. To summarize it, positron emission tomography, we can use it in stage 1, stage 2, just for surgical consultation. If you are not sure or there are equivocal lesions, or you want to go for PEM biopsy and ultrasound biopsy, MRI biopsy was difficult, or equivocal. For neoadjuvant sequence, we'd like to use it for monitoring of response, but that's a local response assessment. And we keep the last option as PEM replacing MRI in certain conditions where there are difficulties to do it. You have to know that technologists are not very much aware of this technology in nuclear medicine departments. So you need those technologists to be trained in radiology department for different positioning. But again, you have to have some kind of shielding between the female or male technologist. And that's an example of a female technologist that shows more imaging, more time spent with the patient, more radiation exposure. That was, in summary, my short and fast lecture, just to try to show that we are at nuclear medicine can do lots of modalities and lots of good acquisition using. Sorry, technically I cannot go back to. Yeah, so we can show that nuclear medicine using only FDG at this point of time has showed an excellent imaging of the tumor, the metabolism, assessment of response. Imagine if we can now replace that with FLT or PSMA or FAPI. So having this limited access in the world, not only in the Arab world, to the PEM, makes us sad. We were lucky in Kuwait to have such a machine. As an official speaker for the company too, I would like to say that now that the company is expanding and selling and promoting for that modality, both for academic and clinical purposes. And I hope that I was short and to the point and changed the mood for you from theranostic to diagnostic. Thank you.
We cannot see any slide.
Thank you, Dr. Fahad, for this excellent presentation and introduction of the new modalities. Now we have the session for question and answers. We already have some answers, some questions posted. First one, it is from Dr. Aysar Khalaf to Dr. Mohammad Haider. Actually, he is asking about the first case, why lutetium PSMA was stopped after the first therapy. I think maybe he's asking about switching to actinium. If Dr. Mohammed can hear me.
Yes, thank you, Dr. Akram. I mentioned that the first patient stopped treatment after second dose due to economical problem. As I mentioned, in Lebanon, the treatment, the patient pay from their own pocket, so sometimes cannot afford to pay the treatment, so they stop it and they refuse to continue the treatment due to economical situation.
Thank you. Also, Dr. Mohammed, you have another question. It is about what are the most common complications that you experience with lutetium PSMA therapy, and what are the most important precautions to take while selecting patients for lutetium or actinium? I think maybe a significant part of this question has been answered already by the presentations, but maybe Dr. Mohammed would like to elaborate a little bit about this issue.
Normally, the most common complication is, as usual, is hematological complication. So we have some grade 3 and sometimes grade 4 hematological toxicity. This is the most common complication. And when we decide to shift from lutetium to actinium, we take into consideration the hematological status first, and the physical status of the patient, I mean EGCG status, before decide if we need to shift to actinium or not. So this is our, and for precaution, we try to, as I mentioned, Dr. Alain, we try to put ice and the salivary gland and parotid glands to protect salivary glands, but for blood there is no other precaution. It's not like DOTA tape, for example. In lutetium PSMA, there is no strict precaution to do.
Thank you, Dr. Mohammed. Actually, I have one question for Dr. Batool. We know that Dr. Batool was from the first persons in the region who started the technetium PSMA. I would like to ask you, how do you compare your experience with technetium PSMA to the gallium PSMA when you switch to the gallium?
You are muted.
You are muted, Dr. Batool.
No.
Okay, sorry. In fact, Akram, the time that we have started the technetium PSMA, we had lots of patients from urology and oncology unit, and for staging, we were doing only bone scan, and bone scan were negative. So those patients that came to us, they had small volume disease and or they were metastatic disease. And we had a comparison of technetium PSMA with bone scan. And we found that all those patients with slightly high or high PSA, they had negative bone scan and positive PSMA scan, technetium. So we found it is superior to bone scan, in fact. Then when we switched to gallium PSMA, we had to do this comparison, and we found that for the small volume disease, gallium PSMA is having superiority to technetium, and also it is more reliable with PET-CT imaging. But then again, we found that tumor, that PSA, which is more than 2 nanogram per ml, the technetium and gallium, they showed the same results.
Thank
Okay.
you, Dr. Batool. Thank you. Thank you, sir. Dr. Khaled, please.
Sorry, Dr. Akram. Dr. Batool, have you tried SPECT-CT with technetium plasma?
Yes, of course. We did all our patients with with the SPECT-CT. Yes.
Okay. Thank you. Thank you.
You're welcome.
Dr. Akram, we can finish.
Dr. Khaled, do you have any other questions or comments?
No, thank you for me.
Maybe also one question for Dr. Fahad regarding the MAMI bit. Is there any kind of reimbursement for this procedure in Kuwait, Dr. Fahad, or those already included? I know that most cancer patients in Kuwait are covered by insurance. Is there any issue about the MAMI because it is still not maybe very well visited in the guidelines?
Well, honestly, there are no radiation exposure consequences of the modality, and there are no extra cost for doing, like, if you remember nuclear medicine, when you do bone scan, you ask for extra images. That's the same concept where you do PET-CT scan, then you ask for more compressed images, focal on the breast. That's the way we are treating with it. We haven't thought of having a dedicated cost for that. Honestly, the compliance we have faced in Jabir is better than the cancer center, because the acquisition on conventional PET takes like 25 to 30 minutes. And if the patient is obese, it reaches up to 40 minutes. We are using in Jabir Al-Ahmed Center for Molecular Imaging a digital MI discovery by GE. We are doing 1 minute per bed. So we are doing like 6, 7, 8 minutes scan for the patient. The patient is more cooperative to have an extra view like Dr. Haider likes to do, which is prone. And also we can do PEM, since the real basic scan is short, you can get more compliance. That's my only note about it. But definitely this is a very good modality, specifically academic people like you, Dr. Mohammad Haider, or clinicians like me and Dr. Akram. We are more interested in having management solution. But for your case, you might think of doing PSMA, FLT, integrin, FAPI, then you might look at different things at very high resolution. We are talking about 2 millimeters.
Thanks a lot, Dr. Fahad. Thanks a lot. Also, I would like to thank all our respective speakers for this session, Dr. Mohammad, Dr. Batool, Dr. Alain, Dr. Fahad, for this excellent presentations and excellent coverage of the topic. Thank you so much. Dr. Khaled, would you like to add anything? Muted, Dr. Khaled.
I want also to thank all of the lecturers, and we can go to the next session for the sake of the time.
Okay, maybe Dr. Akram, we need to move to the second session.
Yes, please.
Immediately. Okay, first, thank you, Dr. Akram and Dr. Khaled, for moderating the first session. Now we'll move for the second session, which will be moderated by myself and Dr. Batool. First speaker will be Dr. Akram Al-Ibrahimi. Dr. Akram Al-Ibrahim, first, he is a friend. We worked together with the Arab Society of Nuclear Medicine, with Dr. Batool. We was the founder of this society, and of course with others. Not Dr. Akram. He is the president of the Jordanian Society of Nuclear Medicine. He's the immediate past president of Arab Society of Nuclear Medicine, and actually vice president of Asia Oceania Federation of Nuclear Medicine and Biology. And he's also chairman of Nuclear Medicine department at the King Hussein Cancer Center in Amman in Jordan. Dr. Akram will talk about the regional theranostic research activity in Jordan. Dr. Akram, we are yours.
Thanks a lot, dear Mohammad, for the kind introduction. Actually, in my topic, I will focus on some recent research activities here at King Hussein Cancer Center in Jordan concerning the theranostic approach. As you know, since the discovery of the cancer genome in 2000 and the analysis of the hallmark of cancers and the microenvironment of the cancer and what is taking place of the processes at the cellular level, there have been many advances in our approach to fight cancer. And actually, nuclear medicine, utilizing its molecular approach, has a significant portion of these advances. However, some of these advances has made inroad from the bench to the bedside, but others, we are still waiting more robust data and more clinical trials to address and give them the clinical phase. For now, we are using many tracers in our clinical practice, like FDG, like PSMA, like DOTATOC, and there are many other new tracers introduced in the last 2 or 3 years, like FABI and like estradiol, which were also presented, some of them presented in the first session of this presentation. So about the theranostic, it is hybrid word. It is thera coming from therapy and gnostics coming from diagnostic. And it is actually starting with a specific observation, then to test this observation and to have action, to try something and to predict the response. At the end, our aim to have better outcome. And theranostic is considered a new paradigm for personalized medicine. And we are in a nuclear medicine community looking at theranostic in 2 approaches. The first one is standalone theranostic provided by radionuclide therapies, started from diagnosis and then therapy by radionuclide therapy. But the second one, which is very important also, providing molecular imaging and to identify some targets that we use now in the new treatment, like we saw in the first presentation about hormone treatment, about specific receptors, about the specific pathways of the cancer that we can target or we can identify by molecular imaging. So nuclear medicine is a new hope and molecular theranostic for cancer patients. And in this context, we can see what we treat. And we achieve this by combination of the diagnostic and therapeutic tools on the same vectors for a specific disease. And this is despite the fact that it has been expanded rapidly in the last 10 years, but this is an old idea started with the nuclear medicine in 1950s with the radioactive iodines, which is considered the prototype for theranostic, utilizing the iodine syntheters. And this leads us now to the personalized medicine, driven by nuclear medicine actually, and we can define personalized medicine in this context, that giving the right treatment for the right patients at the right time and the right dose, and to target the specific tumor of patients, not only the disease itself. All of these can achieve by the nuclear medicine, and we have the advantage of the theranostic by which we utilize the genomic and the proteomic signatures of cancer cells, and we can deliver high specific uptake, sparing normal tissues and targeted metastasis as identified by the pre-imaging modalities. And this would lead us to, or would give us the advantages of effective internal radiation and good tolerability and few toxicities. The concept of theranostic by the key and look principle, and we have now many pairs of diagnostic and therapeutic keys. We have many targets like specific receptors like enzymes inhibitors, like example of PSMA, specific antigens like the HER2s, and specific transporters. Also, we have multiple ligands starting like enzyme, ligands, antibodies, antibody, and amino acid. All of these can be utilized. Also, the pairs of radioisotope between diagnostic and therapeutics. We have many wide arrays of ranges and our pockets for these specifications. Now I will start with some publications published in the last few years and done at King Hussein Cancer Center and Jordan. This one just was presented in the last ARSNM this September, and it is about evaluating the diagnostic utility of gallium DOTATOC and FDG PET-CT scan in high-risk neuroblastoma pediatric patients, and we compare this to the standard modality or the middle, like the MIBG, bone scan, and CT scan. Actually, the rationale for this study that accurate staging of pediatric with high-risk neuroblastoma is actually essential and has implication for prognosis and treatment plan. The standard modality for the detection of extent of metastasis is currently MIBG, CT, MRI, and bone scans according to all published guidelines from the mega societies across the globe. And FDG and PET-CT DOTATOC are now considered a new promising modalities for the evaluation of metabolic status and somatostatin receptors, specifically in the neuroendocrine tumor. So the aim of our studies was to find out if FDG PET and DOTATOC PET can contribute to the detection of neuroblastoma metastatic lesions in high-risk group, and if they are equal or better to the aforementioned standard modalities which are well established, and if they may be used as complementary or even alternative modalities in the staging of patients with high-risk neuroblastoma. And as you know, we can utilize this later on for possible therapeutic approach in case of lutetium DOTATOC, or to commit to our previous standard treatment, which is MIBG. And the methodology, it was a pilot study at 8 pediatric patients with a pathologically confirmed high-risk neuroblastoma who are younger than 18 years were included with no systemic or with no prior systemic therapy. 7 scoring system was used to compare its scoring system for the assessment of the medulloskeletal involvement, and the soft tissue primary and metastatic lesion were assessed based on visual detection and SUV max values for both FDG and DOTATOC PET-CT scan. Actually, in all patients and across all segments, assessed through Seomin score of gallium DOTATOC for the medulloskeletal involvement, the scan modality regarding the detection of bone metastasis. DOTATOC PET-CT scan was the best modality and detect the most lesions, and that followed by the FDG PET-CT scan, then MIBG, iodine 123, and the last was the bone scan with low sensitivity. And in this case, we can see the bone marrow involvement as better detected by the DOTATOC PET-CT scan. In the middle of the, we can see the extent of the involvement in the bone marrow segments in the axial and peripheral skeleton. Also, this was relatively well appreciated by FDG PET-CT scan, but in the DOTATOC PET scan, it was better appreciated and poorly appreciated on the iodine 123 MIBG scan, which, as I mentioned before, it is till now considered the standard modality, and it is the recommended modality by most guidelines. And this is another case about the detection of the bone metastasis itself. We can see in the middle the DOTATOC PET-CT scan. It is clearly detected the multiple involvement in the bone, as well as the involvement of the soft tissue and the primary tumor, and this also was well appreciated on the bone in the FDG PET-CT scan. But if you look to the recommended modality by most guidelines, MIBG, the detection is much less compared to the DOTATOC and the FDG PET-CT scan. So it was in favor of DOTATOC and FDG PET-CT scan. Regarding the soft tissues, both FDG PET and DOTA scan have higher sensitivity, 92% for FDG and 96% for DOTATOC, compared to the current standard examination modality. CT was 84 and iodine 123, MIBG it was 64. And the level of radiotracer uptake, when we compare the DOTATOC to and FDG, it was in favor of DOTATOC compared to the FDG about the visuality. So our conclusion from this research was that DOTATOC has higher detection capacities for medulloskeletal metastatic lesions. of pediatric high neuroblastoma, and both DOTA TOC-BIT and FDG-BIT superseded the standard imaging modalities, CT scan and MIBG. Interpretation confidence was higher for DOTA TOC-BIT CT even compared to the FDG-BIT CT scan and other modalities utilizing the semi-quantitative assessment, the SUV max. Now moving to another study published in 2018. It was actually an innovative approach adopted by King Hussein Cancer Center by introducing the BSMA PET-CT scan for the initial staging of BSM high-risk and intermediate prostate cancer, and this was a study in the molecular imaging and biology in 2018. Actually, we started in this research in 2016, and at that time, it was almost few papers, maybe 6 papers, as I remember from the literature, just addressing the role of BSMA PET-CT in initial staging. Most of the literature at that time was talking about the BSMA PET-CT scan in the restaging and biochemical relapse. So our rationale for this study that was, first of all, we know that accurate primary staging of patients with intermediate risk and high-risk prostate cancer is very crucial for the proper management, and we know that there are many limitations with the CT and MRI in assessment of lymph node metastasis because they mainly depend on the size to have lymph nodes larger than 8 millimeters. And we all know that one scan is very sensitive, but with very limited specificity. And despite the clear superiority of PSMA PET-CT at that time for recurrent and biochemical relapse, but the few literature looked at this modality for initial staging, and we thought at that time that we may introduce something and some new knowledge to the literature when we address the role of PSMA PET-CT scan in the initial staging of high-risk neuroblastoma. So this was our primary objective, is to look at this modality in the accuracy in this regard and to compare it to the other modalities and to see if we can potentially replace other imaging modalities by the new PSMA PET-CT scan. And also we looked at how BSMA PET would upstage or downstage high-risk neuroblastoma and evaluate the potential impact of this modality in the treatment plan of those patients. This is one of the cases that now we encounter in most nuclear medicine department. We can see this is a 72-year-old patient with BSA 74, Gleason score 7. Questionable radiotracer uptake was seen in the sternum in the bone scan. Otherwise, the MRI and abdominal pelvic CT scan were unremarkable for lymph node metastasis. So the initial staging before BSMA PET-CT scan was T3B and 0MX. But when we had this BSMA PET-CT scan for this patient, we can see that from the mid image that there were many pathologic uptake in the abdomen and in the thoracic areas. And when we look to the fused PET-CT scan images, we can see that the patient had multiple highly BSMA-avid, very tiny lymph nodes in the pelvis, in the retroperitoneum, in the thoracic lymph nodes, and then this was the staging was totally changed from T3B and 0MX to N1, M1A, and the treatment plan was changed totally based on the BSMA PET-CT scan. And we know that BSMA, even we can use this modality to follow up of those patients. So in our study, we found that BSMA PET-CT scan has the best concordance when we have done the patient analysis as well as the segment and organ involvement. Also, the BSMA PET-CT scan would sometimes downstage the patient and offer more radical treatment, as we can see in this case where this hypodense liver lesion was highly suspected by the conventional modality, but BSMA PET-CT scan excluded any metastasis at the same time, confirmed the metastasis in the pelvis on the lymph nodes. So this patient was downstage and offered curative treatment. So when we looked at our cohort, BSMA PET-CT scan show higher accuracy than MRI in detecting suspicious pelvic lymph node metastasis, where MRI is, at that time was considered the modality of choice, and BSMA PET-CT scan superseded CT scan in accuracy detection of pelvic lymph nodes and extra-pelvic lymph node metastasis with very significant statistical difference. And also the BSMA superseded the bone scan detection of bone metastasis. So we concluded from this that BSMA PET-CT scan can be used as instead of the traditional modality specifically for the high-risk prostate cancer. And we concluded that this modality seems to be an invaluable imaging modalities in the assessment of a primary high-risk prostate cancer with a great potential for the detection of lymph node metastasis and bone metastasis that would impact the management plan. However, further prospective studies with larger cohort are recommended in order to fully include PSMA in clinical practice guidelines for the assessment of patients with primary cancer. And we have seen many publications in the last few years addressing this issue, and I think that PSMA PET CT scan would be the imaging modality of choice in the early future for high-risk prostate cancer. Based on that publication, we have investigated further in this modality, and we have looked at the impact of PSMA PET CT scan on the radiotherapy planning. And this was published this September in 2021 in the Nuclear Medicine Communication. In this publication, we looked at 108 patients who had PSMA PET CT scan, and they had also radiotherapy treatment either for initial curative treatment or in relapse setting. And the main aim of this study was to explore the potential impact of PSMA on radiotherapy planning, including both the radiation dose and the definition of target volume, as well as we further investigated the impact of PSMA in staging and restaging of prostate cancer. And we have found that PSMA PET has very significant role in the downstaging and upstaging in both settings, in the initial staging of patients, as well as in the restaging when biochemical relapse is suspected. And we concluded from this that PSMA PET has higher accuracy in detecting prostate cancer size when compared to the conventional imaging modality. It has this superiority helps treating physicians to better define the actual extent of the disease. And in our study, the prostate cancer stage was changed in 36% of men compared to the conventional imaging modalities. Identifying disease location helped the radiation oncologist to define the radiation target volume, and the rate in the change of the radiation therapy planning was 31%. And in 10%, the aim of the treatment was totally changed from palliation to radical intent treatment, and this was in favor of the patients. And the PSMA improved the detection of oligometastasis in about 7% of these cases where lesions were targeted with SPRT with potential radical intents. And these are some examples of these cases included or recruited for this study. As we can see in this, just the pre-sacral, very tiny lymph nodes, which was PSMA avid, and the radiation field was modified based on the PET CT scan, and the radiation azodus lines boost the lymph nodes with 64 gray, and was very impactful in the patients. Another case where unusual site of metastasis in the left hilar region, which was confirmed by histopathology, and after that the patient also received radiation isodens lines boost to the lymph nodes with 60 gray over 80 fractions, and after that it was the only site of metastasis, and the PSA declined significantly. Another example where oligometastasis in the sternum was only detected by PSMA PET CT scan, as we can see this tiny sclerotic lesion which was PSMA avid, and after that this patient was targeted by the SPRT, and he received 3 grays over 5 fractions, and then the PSA declined significantly after finishing of the treatment. So in those scenarios, we offer the patient curative intent, and in case of oligometastasis. Another publication mentioned by Dr. Haider about Jordan and Lebanon participated from the region among 15 countries and 17 centers. It was the largest cohort in literature till now, looking at the value of PSMA PET CT scan in restaging of or in the detection of biochemical relapse. And in this paper, we focus in the early biochemical relapse when PSA usually less than, it is still about 4 or a little bit more. So in this case, the nice about and the beauty about this paper that there were participating centers from 4 different continents, including America, Europe, Asia, and Africa. And among all centers, there was no difference in the accuracy of this modality and the impact of this modality on the detection rate of PSMA PET CT scan. Also, as mentioned, and some cases shown already by Dr. Haider, the important points that PSMA PET-CT correlate significantly with the Gaussian score and with the PSA level, and this multi-centric trial has proved the significant role and impact of PSMA PET-CT scan, which has now introduced in the guidelines like the European Urology Association in the assessment of biochemical relapse, and this is considered an achievement for what is considered a relatively young modality in the literature. This is one of our cases in that we participated in this trial. As we can see, the CT scan, almost nothing is appreciated, but on the PSMA PET-CT scan, in this early biochemical relapse, we can detect that there is local relapse as well as very tiny internal iliac lymph nodes only would be detected by this modality, and this patient would offer treatment. Moving to some treatment also approaches and treatment publications, we started the neuroendocrine tumor BRRT treatment back in 2016 and the lutetium PSMA treatment back in 2017. This was our first patient of the treatment by lutetium PSMA in Jordan and King Hussein Cancer Center, and we can see after 2 years, this patient with also this was the last resort for this patient. When he was sent to nuclear medicine, he was two options, either nuclear medicine or palliative treatment. But at that time, we managed to achieve very good response for these patients, and with control of the disease about 3 years and decline of PSA. And as you can see, that between this PET-CT scan 2019 to this PET-CT 2017, almost most of the lesions have had resolved at that time, and the PSA declined from about 500 to 20 with relatively good control over 3 years for this patient. So we published also our first analysis of our patients who are treated by lutetium PSMA, and it was published, it was chosen as one of the top rated oral presentation this year in the European Association of Nuclear Medicine. And we looked at the efficacy and safety of lutetium PSMA in heavily pretreated population with metastatic prostate cancer, our experience in Jordan and King Hussein Cancer Center. The rationale for this, that we know that this modality is a promising new radionuclide therapeutic agent for patients with metastatic prostate cancer, and we started this modality relatively very early when we compare ourselves not only to the Arab region but also to the world, as our previous speakers have mentioned that the Vision trial in the United States just published this year. So I think we have started very early on in 2017 to provide our patients this new hope. So our purpose was in this retrospective data analysis is to evaluate the efficacy and safety of lutetium PSMA for our patients who received this radionuclide therapy by analyzing the biochemical response, their quality of life, and their toxicity profile. And all patients with metastatic prostate cancer who progress after receiving the best available standard of care treatment and received BRRT, this was our inclusion criteria, and those patients who received at least one cycle of PSMA radioligand therapy, and all patients had undergone PSA test before lutetium PSMA therapy. And just to go with you, for this was the patient characteristic. We included 23 patients who treated till the end of the last year in this analysis, and we found those 23 patients already received 73 cycles at the time of the analysis. The dose ranged from 100 to 200 millicurie of PSMA, and with 6 to 8 weeks intervals. And the result, there was a significant decline in PSA of any amount was observed in 78%. Any decrease in the PSA level of patient after the first cycle. After the last cycle, a decline of PSA more than 50 and of any amount was seen in 45% and 70% respectively. Grade 3 and grade 4 hematotoxicity and nephrotoxicity was not observed in any patient. Only brief non-significant decline in production of the blood cells was noted in grade 1 and grade 2. The 21 patients, 91 91% of our cohort reported significant improvement in their patients. And this is the waterfall plot of our patients, and we can see that only in 4 patients who did not respond, but in 19 patients, they have shown very significant response regarding the BSA after first cycle of lutetium, with some patients almost achieved 100% response. Also about the overall BSA results after all cycles received, also we can see that this was achieved in 16 patients, and 7 patients, they did not respond very well to this treatment. And this is according with what is published in international literature and in the best institution in the US and Europe mainly, as well as Australia, where Australia and Europe are considered the leading in these modalities. This is one example of our patients. Usually we do FDG bit and PSMA bit for our patients when we would like to put them on this treatment. And we can see in this case very extensive metastasis by the PSMA PET scan, but also the patient has extensive metastasis, but the PSMA expression is much higher than the FDG. And we can see after 2 cycles, the patient he was in complete remission, and the BSA declined from 172 to 1.8. Also, but it is not always the case in some cases, and this what we have learned over time. We gained experience in this regard. In this case, what we treated by 1 cycle of lutetium, but as we can see from the baseline, the FDG PET CT scan expression was higher than the PSMA expression. The patient received 1 cycle of lutetium, and we repeat the PSMA PET CT scan later on, but unfortunately this patient did not respond to the treatment. And we have, as I mentioned, with our experience, and now such patients, we don't put them on this treatment, and we send them back to the oncologist to seek another possibility of the treatment. And we are more selective in our approach for our patients based on this modality. We concluded from this research that lutetium PSA demonstrates significant activity, achieved significant pain palliation, and had a very limited toxicity profile in those heavily pre-treated population. And serum PSA level during PSMA radionuclide therapy remains a clinically significant predictor of response. And overall survival of those patients will be analyzed in the next stage of this project in light of the biochemical response. So my take-home message from this presentation, that Teranastics is revitalizing nuclear medicine with a great potential in both clinical and research fields. Arab world has been pioneering in introducing and expanding these nuclear medicine-based services to our people. It is not only in Jordan, it is in Lebanon, it is in Saudi Arabia, Kuwait, Emirates. I would say many Arab countries have started early on. Almost as I mentioned, this treatment was initiated in Europe, but I think if we compare ourselves to the other continent, like the US, like America, and Africa, East Asia, we were pioneer in providing these very helpful and very good services for our patients and our peoples. And being up to date in this field would always open great opportunities to excel in both the clinical and research fields. And so we have the opportunity to publish our pilot studies and our pilot papers in highly indexed and highly impacted international journal. And the message from the old theranostic approach now, that molecular imaging is an asset for personalized medicine by in vivo characterization and early diagnosis, linking a target identification with treatment, risk assessment, therapy selection, and monitoring of a treatment. And theranostic or molecular immunoradiotherapy, as German would like to call this treatment based on molecular phenotyping, is considered now a new hope in the treatment of cancer patients, and sometimes it is the last resort for these patients. At the end, I would like to thank all staff and all my colleagues in the nuclear medicine department at Contraindications Cancer Center. Without their help and their efforts, this publication and this research would not be able or doable. And also, I would like to thank you for your attention.
Thank you, Dr. Akram, for this excellent presentation. Now we will move to Dr. Amal Guensi will present now the second presentation in the second session. 1 minute. Yeah. Dr. Amal, she is consultant and head of Ibn Rushd Nuclear Medicine, Director of Nuclear Medicine Program in Faculty of Medicine, Program in Faculty and Pharmacy at Hassan II University in Casablanca, Morocco. She will present thyroid cancer in Morocco, and she will talk about the follicular differentiated thyroid carcinoma in Morocco. Dr. Amal, we are yours.
Thank you, Dr. Haider. Thank you for the Arab Society of Nuclear Medicine for inviting me to this symposium. I remember the first time we met in Vienna and we talked about the Arab Society of Nuclear Medicine. Thank you for all team for making it happen. It will be very hard to talk after Dr. Akram Al-Ibrahim, but I will do my best. So I'm going to talk to you about thyroid cancer in Morocco and especially about follicular differentiated thyroid carcinoma in Morocco. As it's known worldwide, the incidence of thyroid carcinoma, especially follicular differentiated thyroid carcinoma, has increased during the last decade and also in Morocco. It was related to the detection of small tumors with ultrasonography. However, the mortality rate remained the same. In Morocco, it is the same. Unfortunately, we don't have a national register to make the number talking, but we touch this increase in rates. So, in my talk, I am going to talk how does follicular thyroid carcinoma behave in Moroccan patient. By reporting patient epidemiology, serological type, and response to initial treatment. And also, I'm going to talk about how do we manage follicular differentiated thyroid carcinoma in Moroccan patient. And I am going to finish with the challenges and perspective that we have to do to improve management of patients with follicular differentiated thyroid carcinoma in Morocco. So in Casablanca region where I work, we can move to the next slide, cell. In Casablanca region, where I work in the registry, local registry of cancer, each year we do have 25,000 new cancer patients. Among them, there is 1,325 new thyroid cancer. The region of Casablanca represents 12.6% of our Moroccan population. It's like 5 million inhabitants in the big region of Casablanca. If we look to the distribution of cancers, we are going to find that thyroid cancer will be in the 6th position after breast cancer, lung cancer, colorectal cancer, cervical cancer, and prostate cancer. It represents 5.5% of all cancer. Now, if we look to the distribution among gender, we can find that in male patient, the thyroid cancer is in the 30th position with the 1.6% of all cancer. In female, however, in female, it is in the 3rd position after breast and cervical cancer. and it represents 8.6%. This specific rate we were increasing with age, reaching a peak of 45 to 54 years old in male patients, and it reached 55 to 59 years old in male patients. So male patients are more aged than female patients. So before talking about the behavior of follicular differentiated thyroid carcinoma in Moroccan patients, I will represent my department. So my department was created in the late of 2003 and first month of 2004. It's formed by 2 units, 1 unit for imaging. We do have a one SPECT CT, and one PET CT. And also we do have a radioiodine therapy unit with 6 rooms currently. We started with 2 rooms in 2008. So how do Moroccan patients behave? We are going to talk about this throughout a medical thesis was done in my department about 740 patients. This work was looking to highlight on prognostic factor in follicular differentiated thyroid carcinoma in Moroccan patients, and we aim to analyze their impact on treatment response, especially on radioiodine efficiency. So we have included 740 patients. Among them, 89% were female and 11% were male. So we have 8 female for a male. Thyroidectomy total thyroidectomy was done in 100% of patients, in one time in 57% of patients, in two time in 43% of patients. Lymph node surgery was done in 16% of patients and was positive in 56% of them. Radioiodine therapy was given to 95% of patients, and the activities were between 100 millicurie and 650 millicurie. Our patients have an average age of 43 years old in outpatient, and also in papillary thyroid carcinoma patient. Follicular thyroid carcinoma patients were more aged with an average age at 51 years old. 66 of our patients were aged between 19 and 55 years old. Only 3% of our patients were aged under 18, and 21% of them were aged up to 55 years old. Looking to the histological type, papillary thyroid carcinoma was the more frequent histological type. 90% of our patients had papillary thyroid carcinoma, only 8% had follicular thyroid carcinoma, and 2% of them have oncocytic thyroid carcinoma, followed later into WHO classification as hard cell carcinoma. Also, we do find that in papillary thyroid carcinoma, 5% of our patients have variants to papillary carcinoma with some favorable histology as trabeculovesicular carcinoma. In follicular thyroid carcinoma, we do find that in our patient, there was association with the undifferentiated form as insular carcinoma. So, in this work, we reclassified the patient according to the TINAME 8 edition. We found that only 5% of our patients are classed high risk by the tumor size. 8% of them were metastatic, and 10% of them have lymph node invasion. The metastatic patient have follicular thyroid carcinoma. The most of them have follicular thyroid carcinoma. So In follicular thyroid carcinoma population, 24 of them have metastasis, and only 6% of papillary thyroid carcinoma have metastasis. These metastases were located in the first site in lung, with 60% of papillary thyroid carcinoma and 36% of follicular thyroid carcinoma. The second set were bone. The second set was bone with 30% of papillary thyroid carcinoma and 36% of follicular carcinoma. And the third set was association of lung and bone metastasis. So for papillary thyroid carcinoma, the metastases were in the first place in lung. However, for follicular thyroid carcinoma, it was in bone and also in bone and lung, as it's reported by international literature. There is an image of male patient aged 57 years old who had revealed his follicular thyroid carcinoma with broken his femur. So after radioiodine therapy, the whole body scan showed many metastatic location in bone and also in lung. The patient did 6 months after this radioiodine therapy by complication of pathological fracture of his femur. So in our patient, they do receive radioiodine therapy in 1 or more times. The total activity was between 100 millicurie and 1500 millicurie. The complete response was seen in 74% of patients. Ischemic disease was seen in 90% of patients, and 7 patients were unprogressive disease. In the images shown up, we have a patient with residual tissue of thyroid, and then after radioiodine therapy, 9 months, we assess the efficiency of treatment, and the patient was with a negative whole body scan and also with a negative thyroglobulin rate. In the bottom, we have whole body scan, post-radioiodine whole body scan in young woman aged 18 with the residual tissue in thyroid area, and also with adenopathy in mediastinum and with lung metastasis. After 2 cure of radioiodine, the patients were clean of any fixation, and thyroglobulin was negative and still negative in the follow-up of this patient. Regarding to a prognostic factor in our population of patients, we found that age up to 55 years old, follicular histologic type, tumor size up to 4 centimeters, multifocality, bilaterality, the absence of capsule, the effraction of the nodular capsule, and the effraction of the thyroid capsule, also as the presence of vascular invasion and metastasis lymph node invasion, and also the presence of distant metastasis was a significant prognostic factor in our population. So in these patients, we do have to make a therapeutic strategy according to their risk and according to the impact of this prognostic factor on their response to treatment, and we have to be more aggressive in this patient. So I would like to share with you another study we done in my department between 2008 and 2020. We include 121 patients, metastatic patient of follicular differentiated thyroid carcinoma. We do have 77% female and 23% male. 72% of our patients were patients with papillary thyroid carcinoma. 28% of them were with follicular thyroid carcinoma. In this patient, they do have total thyroidectomy in all cases. Then we done radioiodine therapy. We done one cure in 37% of patients, 2 cure in 36%, and 3 cure or more in 27% of them. At the end of follow-up, we found that among our patients, 68% of them are in progressive disease, 18% are in biochemic disease, and 7 are died from their cancer disease, and 7 were in a complete response. Only 7 patients with a complete response to treatment. So how we do manage the follicular differentiated thyroid carcinoma in Morocco? I'm going to start with the patient before surgery. When the patient came to the first visit before surgery, he will be investigated with ultrasonography, maybe CT scan. The fine needle biopsy is not used a lot in Casablanca. So if the patient has a goiter, he will have a total thyroidectomy. Then the anatomopathologist reports if he mentioned malignancy, the patient will go to radioiodine therapy and L-thyroxine replacement. If not, he will have only L-thyroxine replacement and will be followed by endocrinologist. If the patient has a thyroid nodule up to 1 centimeter, ThyRADS 3, 4, or 5, he will have extemporaneous exam if possible. If malignancy is reported by the anatomopathologist, the patient will go to total thyroidectomy. If extemporaneous is not possible, the patient will have lobectomy, and if malignancy reported by anatomopathologist, he will have a completion of thyroidectomy in next time surgery. And then he will go to radioiodine therapy and the L-thyroxine replacement if malignancy is reported in the anatomopathologist report. Then after, he will have a follow-up adapted to his risk. Looking to the lymph node surgery, surgeon will move nodes if the patient is T3 or T4, or if there any evidence of lymph invasion by the tumor before surgery or during surgery. However, in those patients, lobectomy in low patient is under considered. There is some resistance in surgeon for lobectomy. They are afraid to have to reoperate the patient, and they are afraid of complication will be seen after a second time surgery. So now I'm going to talk what's happened after surgery. When we received the patient in nuclear medicine department, before 2017, we used the European guideline for the management of differentiated thyroid carcinoma. Even after the publication of the ATA guidelines, because there was also some resistance in my own department from my colleagues to accept the recommendation of ATA, because they are also afraid to let patients without radioiodine therapy, even if the risk is low. So we first, with the first risk assessment according to the European guideline for management of differentiated thyroid carcinoma, and then the patient will have L-thyroxine replacement to have a TSH around 0.1 microunity international per milliliters. His radioiodine will be scheduled. Then we are going to assess the thyroglobulin antibody and TSH ultrasensitive 3 months later, because as we are the only public structure to offer radioiodine therapy with 6 rooms for all the Moroccan territory, it was hard to to include all patients for radioiodine therapy without delay. So when the radioiodine appointment come soon, we can hospitalize patient and he will have his radioiodine therapy after 4 to 6 weeks of withdrawal of L-thyroxine. After the radioiodine therapy, he will have his whole body scan 72 hours after, and he will leave the nuclear medicine department under L-thyroxine therapy. So then after, we can assess the TSH ultrasensitive 3 months later to verify if the patient is correctly framed. And then we reassess thyroglobulin ultrasensible and antibody thyroglobulin 6 to 8 months later. We used to use whole body scan, iodine whole body scan to assess the presence of residual disease, but we don't use it anymore. So the complete response was defined as undetectable thyroglobulin with negative antibody and with absence of any morphological disease. Currently, we use ultrasonography to assess if there is any residual disease. If the patient is in complete response, then he will be addressed on the endocrinology to be followed for his L-thyroxine replacement and his annual assessment. If there is any persistent disease or relapse, the patient will be rescheduled for radioiodine therapy or surgery after multidisciplinary staff. So after 2017, the things move on, and we all the team accept the ATA recommendation and accept to assess the risk in the first visit. So then we can reclassify the patient on low risk or intermediate or high risk. If the patient is low risk of recurrence, there is no indication of radioiodine therapy. So we are going to assess thyroglobulin antibody, and put the patient under L-thyroxine replacement to have a TSH around 0.25 microunity international per milliliter. If there is any histology defavorable or raising in thyroglobulin or thyroglobulin antibody, the patient will consider it otherwise. If the patient is low risk, he will have L-thyroxine to have TSH around 0.25. And then we are going to reassess thyroglobulin antibody and ultrasonography 6 months later. And then after once a year, and the patient will be sent on the endocrinology to be followed there. If there are any defavorable factor during the assessment, the patient will be reconsidered for radioiodine therapy if there is any suspicion of residual disease. In patients with intermediate or high risk, there is indication of radioiodine therapy. We administer the radioiodine therapy after 4 to 6 weeks of L-thyroxine withdrawal, and we will have a whole body scan after 72 hours after radioiodine therapy. After the radioiodine therapy and whole body scan, and also we assess the thyroglobulin and anti-thyroglobulin antibody. At the end of the radioiodine therapy, the patient will be reassessed, and the risk will be reassessed also. 3 months later, we are going to assess the SASH ultrasound to verify the L-tyroxine therapy is the objective. The goal is obtained according to the risk, and everything is okay. The patient will be reassessed 6 to 9 months later by thyroglobulin ultrasensible, thyroglobulin antibody, ultrasonography to assess the efficiency of initial treatment.
Dr. Amal, your time is getting over.
Okay. There is, I think, 3 diapositives. So after, if the patient is in complete response, he will be followed as his risk, as his new risk assessment. If not, he will be having a new radioiodine therapy or surgery. So what are the challenges and perspectives to improve management of patients with follicular differentiated with carcinoma? The first thing is to de-escalate the treatment because the Moroccan patients are overtreated. So we have to reconsider lobectomy in the special low-risk patient. And also we have to reconsider radioiodine therapy if the patient is low risk. Also, we have to consider active surveillance versus surgery in small nodule. And for that, we have to convince our colleague surgeon to accept the active surveillance versus surgery in very low-risk patient. We can go to the conclusion, if possible. We also have to consider dynamic reassessment for all patients. And we can also go to the prospective cohort study to highlight specificity of differentiated thyroid carcinoma in Moroccan patient, to highlight prognostic factors specific to Moroccan patient, and also to highlight genetic abnormalities in Moroccan patient, so we can adapt treatment to disease aggressiveness. And thank you so much.
Dr. Batool, you are unmuted.
Yeah, as usual. Thank you, Dr. Amal, for your presentation. Now I think is Dr. Abdullah or Dr. Khaled? Yeah, Dr. Khaled.
Dr. Khaled, we will go for Dr. Khaled.
Yes, Dr. Khaled is consultant and professor of nuclear medicine in the Military Medical Academy in Cairo, Egypt, and he's going to talk about the value of PET in breast cancer.
Bismillah ar-Rahman ar-Rahim. I feel grieved to be the last or before the last in this very condensed symposium, but I try to make my talk very light. I will start firstly by my the home message. My home message for my colleagues or for my students or juniors is in any center of nuclear medicine having PET CT, there is a very and concerning with women health. There is a very good add value and the benefit or positive impact of adding a small dedicated breast bed in this unit, because as in general we can call that as one-stop shopping. In Egypt, we have now 3 cyclotrons, and we have our FDG, sure, and we have now technetium generators and radioactive iodine produced from the Egyptian Authority of Atomic Energy. And we have almost 70 PET scanners now. 3 of them are dedicated breast PET scanners or devices. And all of these 3 are in the private sector, not governmental. And they started work 1 year ago, almost, or 18 months, and their output is, I think, is from my opinion, very, very positive and very beneficial for the females. Also, our governmental has initiative for breast cancer women, and they targeting almost 20 million ladies in Egypt. And these 20 million ladies, if we say at least 100 or 1,000 from them has indeterminate results, so they may need additional accurate or much better imaging modality to verify their finding in a screening, in this mass screening project in Egypt running now since 2 years. So I talk in brief about the add value of dedicated breast PET and what are the types available in the market. And I think by one injection of FDG, one injection of FDG, we can make both very, very small sized lesions detection, and also we can make surveillance for or survey for the whole body, targeting the regional lymph nodes and the distant metastasis. What really matters on breast cancer detection, as I said, so the early detection. We are looking for spatial resolution down to 1.6 millimeter. 1.6 millimeters is a lesion like, as an example, a grain of rice. This is the capability of, this is the resolution of the dedicated breast devices. But the conventional whole body PET scanners can detect up to or down to 6 millimeter. 6 millimeter is as a grain of bean or as a grain of bean. So this is the difference to what is better, to detect a grain of rice volume or like lesion, or to detect a grain of bean like lesion. Of course, if it is smaller, it is much, much better because it is much earlier than the larger lesion. Also, we are also targeting to less radiation exposure, less effective dose for the patient. And because if we can repeat the test, as an example, in neoadjuvant systemic chemotherapy monitoring, so we need the less exposure dose. And less exposure dose, also the dedicated breast scanners or devices can reach now for 1/8 of the dose of the FDG. So we can do once the staging workup, including the primary characterization, and then we can follow up. If the patient needs neoadjuvant chemotherapy, we can follow up by dedicated breast by 1/8 of the dose. As an example, if the patient will take 8 millicurie FDG, we can give the patient down to 1.5 or 2 millicurie maximum, and we can reach the answer of the clinical question of referrer. Is this therapy favorable, of good response or not? And this neoadjuvant therapy, when could we stop it. Also, some inconclusive images and especially in high-risk women, we are in need for accurate image diagnosis, and accurate image diagnosis needs more resolution. So this is also one of our requirements. Breast reconstruction. Breast reconstruction is, as an example, as exophytic structure outside the body, and so it should be dealt with physically by in reconstruction of the computer by better positioning. What is the best positioning of the breast in reconstruction from the physics view? The prone position of the patient is better than the supine position, so we conventionally make a prone position after ending the whole body scan for the breast, and to make the reconstruction better, and also the compression decreases the reconstruction. So without compression and in prone position, we can reach the best reconstruction of the breast structure. Actually, there are now 6 different imaging techniques to diagnose breast cancer. Our nuclear medicine are the 3 that could be claimed that of high specificity, maybe with respect and whole body PET and dedicated PET scanners or devices. And the high sensitivity or the screening modalities include mammogram and tomosynthesis, ultrasound, and MRI. What are the facts about breast cancer behind this talk? All of us know that PET-CT using FDG is based on the principle of elevated glucose metabolism in malignancy, what's called Warburg phenomenon after Otto Heinrich Warburg. So its use in breast cancer patients is frequently being investigated. It has been shown useful for classification that is called primary detection or characterization from the start, staging, therapy monitoring, and both in primary and recurrent disease. Several studies have demonstrated that tumors with unfavorable prognostic criteria show higher degree of metabolism. Due to the limited resolution of most of the whole body scanners, due to suboptimal patient positioning and the partial volume effect, sensitivity for visualization of small primary tumors less than 6 mm found to be very low. Despite the limitation in primary tumor visualization with PET-CT, there is an increased demand for accurate tumor visualization. Still, there is very high demand for metabolic imaging with FDG and quantification of its metabolic activity. PET-CT can be used in patients with dense breast glandular tissue, in which mammogram and ultrasound and MRI shown to be less accurate. To improve the detection and the quantification of primary breast tumors by FDG, several dedicated breast PET devices have been developed. The 4 devices depend according to the positioning of either the breast of the patient or the patient himself or herself, using either compression of the breast with what's called upright positioning, this is a BEM, or with having breast without compression in the prone position, and this is BEM PET or dedicated breast PET-CT or mommy PET. So again, the indications, the dedicated breast PET clinical indications in accurate quantification of the radiotracer, and the next slide I will what is meant by accurate quantification of the radiotracer uptake, and also lesion characterization, and this is very important in therapy follow-up and monitoring, especially with using neoadjuvant systemic chemotherapy. In this dense breasts and in post-operative follow-up, and in patients with contraindications for MRI. This is the only solution at that time, and with breast implants because of the risk of beneath or underneath the implant recurrence of locally recurrent, and in inconclusive mammogram or MRI. Here is a small cartoon about the structure of the mummy bed, one of the 4 types or the types of the dedicated breast bed. This is one ring, LISO. This is a LISO detector, 12 detectors, and it could be 1 ring or 2 rings. And this structure, because the breast is inside the detector, we can reach down to 2 millimeters in resolution or in lesion detection. So it is very important and essential for early breast cancer detection, and in any inquiry in patients imaging during screening to and a lesion found to be characterized or verified by such an imaging modality. Here is this slide is very important. We have 4 parameters: the SUV max, semi-quantitative parameters, SUV max, SUV mean, and what is called background variability and contrast variability. These 4 parameters were measured against or opposite the dose reduction, opposite 100%, and with reduction the dose up to 1/16, and we found that up to 1/16 of the initial dose of the 100 dose, no difference in the quality of the image and the capability of detection, and even in the semi-quantitative measurement. Here is an example of negative breast exam. The breast very homogeneous without any focal density up to pinpoint. Nothing is seen here in this normal negative breast exam. So here in such image, this the negative predictive value of such image is, I think, it reaches 100%. Here is another positive mammogram. We have also to give our concern to 2 types or 2 patterns of mummy scintigram. The 2 patterns, the multifocality and the multicentricity. Multifocality in the foci or the satellites, as Dr. Fahad said before, in 1 quadrant, but multicentricity is the abnormal tracer fixing or utilizing foci are scattered in other quadrants. So the management plan or the surgical management plan will differ completely from multifocal, from multicentric, from one only solitary lesion. Here is multicentric, and the conservative surgery is questionable in such patients. Another very important indication or impact of the dedicated breast bed is the pleomorphic pattern of the lesion is very important. Why it is very important? The pleomorphic means there is variable pathologies in the same lesion or variable degrees of aggressiveness in the same lesion. It guides this pattern, should guide the biopsy. And now starting the bit guided biopsy is starting to develop, and this innovation depends upon the pathology is heterogeneous. And if the pathology is heterogeneous, also the response of the therapy will be heterogeneous. And the clinicians, many times the clinician don't want to hear what is called bimodal therapy response. Bimodal therapy response is refused for the clinician. But I have the document, I have my evidence. My evidence is the pathology is also heterogeneous. How the heterogeneous pathology responds homogeneously. So this is my document, and this is the pleomorphic pathology of the lesion should be considered as a trigger of pleomorphic therapy response, and it is also important in biopsy guiding. Also, why we can use now we are in the era of complementary investigations, not in the competition at all. We can use everything for, as Dr. Haider said before, for the health care of the patient. Anything helps, we can use it. Nothing for competition now, but we have to take care from the economics. The economics is very important. The medicine is business also. So we have to, the economic factor we should consider. And here, this image fusion of MRI with dedicated breast PET, it is made by what is called software. It is very, very easy. By my workstation, I can make by expansion and contraction or anything, retraction, I can make fusion between the PET and the MRI and take the advantages of MRI and the advantages of PET. Here is a case, first case to show to you. Patient presented with suspicious right breast mass lesion. Left breast is unremarkable. The mammogram shows right upper outer quadrant BRADS 4C, and the lesion is very clear, and it extends from the upper to lower outer quadrant. Here is the lesion. And the lesion by semi-quantitation of SUV, this here is the background. Here is lesion 1, 2, 3, and here the SUV max is 2.5. Here was 6. Here was 9. So there is a heterogeneity in the density of the avidity, and this heterogeneity of avidity may reflect heterogeneity in the pathology. And actually, this patient was pathologically proven to be polymorphic carcinoma, lobular carcinoma. This is the coronal view. This is the sagittal view of the right breast, of the diseased breast. Here's also quantitation of the lesion itself. This is the lesion size, which is very important if we will start a new adjuvant systemic chemotherapy to follow up after 1 or 2 cycles the size of the lesion and the metabolic activity. Left breast is free. Here in another case. Here is another case. Before treatment, this is multifocal invasive, 3 lesions, and after or during the new adjuvant therapy, we can notice a very, very tiny, very subtle lesion here with very low activity from this largest lesion still present. But the new adjuvant therapy that targeting what is called T downstaging is successful. Here from another plane, the lesions totally resolved. 3 and 2, but the first one still a very small, this is only after one cycle. And this lesion is 0.02 centimeter, cubic centimeter, 0.02. 0.02 means we talk about 1.6 millimeter, 1.6 millimeter here. And this is its volume. And I swear, no conventional whole body PET-CT, even digital scanners could reach this down resolution. It is not precedented at all by any conventional whole body scanner. Another patient. Here as an example, 2.5 lesion, and here is 0.2 cubic centimeter. This lesion, 0.2, the previous one in the previous slide was 0.02, and here is 0.2. 0.2 is the least resolution could be detected, or the least lesion size could be detected by conventional whole body scan. But as an example, here this is complete response. Complete response means successful down staging, but still there is a point, maybe 0.01 cubic centimeter. Very, very, very small, less than pinpoint, but it could be detected, and it is known that was before larger, and it is this after the new adjuvant chemotherapy response and successful T downstaging. Here, I don't like this this expression versus, but I have to show this slide. Here is a lesion with steadily rising tumor markers, and it was left breast mastectomy 3 years ago, and by whole body it was free, but here by mommy there is a retroareolar lesion, a very small lesion missed by all other techniques. So this is the add value. This is the add value of dedicated breast PET scanners. Here also mommy versus indeterminate MRI lesions here in this breast, and it was false positive by mommy PET. So 100%, because the true negative predictivity or predictive value of mommy PET is 100% almost. So here no doubt or no suspicion to have any lesion here in this breast that was shown by MRI as worrisome for us. So to conclude my talk and to confirm again my home message, we in any center concerning with women healthcare, and it has a PET-CT scanner, whole body conventional, it is beneficial or of add value to have a dedicated breast PET within this center, because it has a beneficial complementary test following the whole body PET-CT that offers some important advantages, such as the whole body advantages evaluation of systemic disease, chest wall invasion, whereas the dedicated breast PET increase the spatial system resolution, may aid in early detection of small lesions down to 2 millimeters, not visible by whole body, and promising in detecting multiplicity or multicentricity. This is very, very important, and also detecting any small, very small lesion in the contralateral sound breast. So dedicated breast PET appears to be able to better depicting heterogeneity in tumor FDG uptake, especially in larger tumors, and this will explain the heterogeneity also in the therapy response. This aspect may enable FDG guided biopsy for more accurate histogenic tumor profiles in breast cancer patients scheduled for new adjuvant systemic chemotherapy. With dedicated breast PET, it is possible to visualize primary breast cancer lesions in prone position without compression and without the limitations known for PET-CT whole body for optimal size and histological subtype. Thank you very much.
Thank you, Dr. Khaled, for this excellent presentation and overview about the role of mummy PET. And really, there is many indication, but till now there is no clear guidelines for mummy PET in the literature. So maybe we need more study about it and how to increase the use of this technique. Thank you very much. There is no question in the box. Do you have any question, Akram, in the box?
I think I have maybe 2 questions.
Yeah.
The
Please.
first one, yes, from question for Dr. Akram. In your research article comparing MIBG and DOTATOC PET-CT, do you think that the MIBG had been underestimated due to better resolution of PET compared to SPECT? And do you think that a comparison of Avdoba as a PET tracer may be more fair? Totally agree with this comment. And this will be raised in our discussion. It is a very valid point that we use most of these cases the planar imaging for the MIBG, iodine 123. But also regarding the Avdoba, till now it is not available, but it is known from literature that it is one of the best PET modalities for the assessment of neuroblastoma. I think this can be a topic for future research. It is very important to compare the DOTA and the DOBA and FDG in different scenarios. However, with the other modalities, we addressed important questions regarding the role of DOTATOC PET-CT because it is widely available in many institutions worldwide, and about also we all know how complications we have in the logistics of the iodine 123 MIBG scan, which is considered one of the modality of choice for the assessment of neuroblastoma. So having alternative modality like DOTATOC PET-CT scan is very fruitful and would be very helpful for most nuclear medicine institutions. Once you have Avdoba, and we may compare both modalities. And I think maybe few papers have compared this in the literature, 1 or 2, and they found comparable results or some superiority for DOBA with some concern about these studies. Also, this takes us to the other question from Dr. Aysar about that if gallium DOTATOC is the modality of choice for neuroblastoma. As I mentioned, if we have, according to what modalities that you have, if you have Avdoba, this should be addressed. Maybe it is better than DOTATOC, but I think that DOTATOC has very high accuracy for assessment of neuroblastoma. Also, it has a major advantage that it may stratify theranostic approach for those patients, because even we know that MIBG treatment for neuroblastoma has been for a long time one of the good palliative treatment for those patients. But I believe also that lutetium dotatate would have a role in the early future in this regard. This is my answer to the questions which are posted, Mohammed.
Thank you, Akram. Because I have a technical issue, so I cannot see the question and answer. Dr. Batool, do you have any question in the box? Mute yourself.
This regarding DOTATOC that Akram answered, and there is one question: what is the mean difference between PET-CT and SPECT-CT?
For me, Batool, okay, okay. Both are hybrid modalities. It is about maybe it's a medical student, or however, the main difference is the radionuclide that we use. In PET scan, we use the positron emitters, radioisotopes, like fluorine, gallium-68. In SPECT, we use usually the gamma emitters, okay, radioisotopes, or the low energy radioisotope like technetium and PET CT scan has better resolution compared to the SPECT CT. And these are some of the aspects, but this needs a long basic lecture to answer this question. Okay.
Yes, I agree.
Could I add a small remark also about the difference between?
Please, Dr. Khaled.
The SPECT CT mechanism of acquisition is stop and shooting, but the PET CT is continuous acquisition. This is by virtue of the ring construction of the detector of the PET CT, but the SPECT CT is two detectors, and so they have to move and make stops, and with every stop they can make their acquisition. So stop and shoot is very, very less in resolution and sensitivity than continuous acquisition by the complete ring construction or structure or design of the PET scanners.
Okay, thank you.
Before I leave you, I have a suggestion, Dr. Muhammad, for you and for Dr. Ibrahim, for Dr. Akram. I want for the future events, I suggest to make it on Fridays, if possible. Friday, because
excuse me, in what?
The future events.
On Friday,
yes.
Okay.
If possible.
ما عم بسمع أكرم شو قال؟
Dr. Khaled suggested that to attract more audience from the region, that Friday is the best day to have such activities.
Yes, okay.
Okay, Dr. Khaled, you have one question also. Nice lecture regarding dedicated breast imaging. The question is, how expensive is the dedicated breast PET machine compared to PET CT machines?
1/5 or 1/4 maximum.
How much?
1/4. 1/4.
1/4.
Yes.
So we are talking about $250,000, something like this.
Yes. Not more than that.
Yes.
Okay, so
machines with one ring and machines with two rings, and we can recommend or advise by one ring at the beginning before the budget constraints.
Okay, thank you. So I think we can move to close the symposium. Thank you very much all. Thank you for the participant and for the speaker. Thank you for Jean-Luc Urban for your participation, and hope see you soon in other symposium with all the participants and speakers from the region, and we'll take your suggestion into consideration, Dr. Khaled. Thank you very much. Any word, Dr. Akram, Dr. Batool, Dr. Khaled, Dr. Amal?
Thank you very much. Thank you.
Thank you, Ahmad, and we'd like to thank all participants for being with us at this event. And that's it. Thank you.